Hello, and welcome to Zero's second annual Health Equity Symposium. I'm Dr. Reggie Tucker-Seeley, Zero's Vice President of Health Equity. This virtual event continues our conversation from our June 2021 Racial Disparity Symposium. The event today will continue highlighting where we see the largest disparities and what we all can do to eliminate the differences we see in prostate cancer for different groups, such as by race and by where people live. Our topics today range from racial diversity in clinical trials, to the influence of the neighborhood environment on prostate cancer risk, to issues related to cardiovascular disease and prostate cancer. I will start our event today with a discussion on what is health equity. But before we begin, I want to thank our sponsors, our silver sponsors are Bayer, Blue Earth Diagnostics, Myovant Sciences, AstraZeneca, Sanofi, Pfizer Oncology, and Astellas. Zero is proud to partner with all of our sponsors as we address the many topics surrounding health equity and prostate cancer. And now, what is health equity?
Embarrassed. Too embarrassed to speak to a loved one. Too embarrassed to speak to your doctor.
Too embarrassed. When in our lifetime, 1 in 4 Black men will be diagnosed with prostate cancer. 1 in 12 Black men will die from prostate cancer.
Let me repeat that. 1 in 4 Black men will be diagnosed with prostate cancer. 1 in 12 Black men will die from prostate cancer disease.
1 in 12. That could be your dad, even your older brother.
Embarrassed. Too embarrassed to speak to a loved one. Too embarrassed to speak to your doctor.
Too embarrassed. When in our lifetime, 1 in 4 Black men will be diagnosed with prostate cancer. 1 in 12 Black men will die from prostate cancer.
Let me repeat that. 1 in 4 Black men will be diagnosed with prostate cancer. 1 in 12 Black men will die from prostate cancer disease.
1 in 12. That could be your dad, even your older brother, uncle, or grandfather.
You need to make sure they are not embarrassed to speak to you or their doctor about it.
Hey, Dad, have you had your prostate checked out? See? How hard is that? It's easy. Just start the conversation.
Prostate cancer is survivable if caught and treated early enough.
Don't let embarrassment stop you having this important conversation.
You may save someone's life.
Not just your own.
So I apologize for those technical difficulties there at the beginning. But that was a film, a video by Sir Steve McQueen, the noted filmmaker of 12 Years a Slave. And the effort to create this video was led by Mr. Patrick Cox, CEO of Male Cancer Awareness, to highlight the differences in prostate cancer between Black men and other racial and ethnic groups. The statistics presented in that video are for the UK. And today you will hear what those differences look like here in the United States. But regardless of whether we are talking about Black men in the UK, the US, or other places, we have worse health outcomes and prostate cancer specific health outcomes compared to other groups. The goal of efforts to reduce or eliminate disparities in health-related or healthcare-related outcomes is to achieve health equity. But what is health equity? So hello, again, my name is Reggie Tucker-Seeley, and I'm the Vice President of Health Equity here at Zero, the end of prostate cancer, and I'm going to give you a brief presentation on what is health equity. Before we do that, again, we want to thank our silver level sponsors, Bayer, Blue Earth Diagnostics, Myovant Sciences, AstraZeneca, Sanofi, Pfizer Oncology, and Astellas. So I'll start with talking about cancer disparities and health equity. While today, our Health Equity Symposium, we will be talking about prostate cancer, the term health equity can apply to our overall health generally. The Centers for Disease Control defines health equity in reference to our overall health as follows. Health equity is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. Now, a substantial focus of the Health Equity Symposium today will focus on the impact of cancer on the Black community. Now, why is that? Well, Black men have the highest overall cancer mortality rate, 221 per 100,000, and that's higher than any other racial or ethnic group in the United States. That's 19% higher than for white men and twice that of Asian and Pacific Islander men, who have the lowest rate. And prostate cancer mortality among Black men is more than double that of any other racial or ethnic group. And Black Americans, we only account for approximately 14% of the population, but we have the highest death rates and survival rates of any other racial or ethnic group for most cancers. Now, the figure presented here represents the cancer journey from prevention, screening, and detection, diagnosis, treatment, survivorship, and all the way to end-of-life care. Now, across this spectrum, because of differences of where we live, learn, work, and play, differences because of historical policies that have done things like sort us into different neighborhoods because of our income or our race, different levels of access to high-quality healthcare, we see differences by racial and ethnic groups across this spectrum, from our ability to prevent cancer generally, to get screened for cancer, to get treated for cancer, and to survive cancer. The factors contributing to those differences are the social environments in which groups live in the United States. In particular, the places where we live, but also where we learn, where we work, and when we play. Those places are distinctly different depending on one's racial or ethnic group membership and or income. The social determinants of health, or the conditions where we live, learn, work, and play, have a substantial influence on our health behaviors, and on how we navigate healthcare. Healthy People 2020, which is the federal government's program for monitoring the health of our citizens, provides a framework for the social determinants of health to identify the pathways to create social and physical environments that promote good health. The components of this framework include our neighborhood environment, and in that neighborhood environment, our access to foods that support healthy eating patterns, whether or not we're exposed to things like crime or violence. Our health and our healthcare, that is, do we have access to healthcare, access to primary care? How health literate are we? Our social and community context. So during the COVID-19 pandemic, there was a lot of discussion about social isolation and the importance of our social and community context. Also, our level of education, our access to education. Early childhood education, enrollment in higher education, our language and our literacy. And lastly, our economic stability, whether or not we're employed, we're exposed to food insecurity, housing instability, or poverty. And it's deprivation in these conditions, like our healthcare, our neighborhood environment, it's deprivation in these conditions that produce poor health outcomes. And it's the differences in the distribution of that deprivation that produces the disparities that we're going to talk about today, that is differences by race and by place. According to the National Cancer Institute, Cancer disparities reflect the interplay among many factors, including those social determinants that I just mentioned, but also things like our health behavior, our biology and genetics, so the things that we inherit from our families. It is the interplay of all of these things which can have a profound effect on our health, including our prostate cancer risk, our outcomes, and also disparities. So what are we doing at Zero to work towards achieving health equity? Well, we created this video to describe what health equity means at Zero.
All men are at risk for prostate cancer. So no matter who you are, you want to have a fair and just opportunity to prevent, find, treat, and survive prostate cancer. And when everyone has the same opportunity, that is health equity. Unfortunately, different groups of people face more barriers when they try to prevent, find, treat, and survive prostate cancer. And these differences can be explained by biological, social, environmental, and healthcare-related factors. The largest differences are experienced by Black men. For example, when comparing Black men to other racial or ethnic groups, Black men in the US are over 1.5 times more likely to be diagnosed with prostate cancer and over 2 times more likely to die from prostate cancer. These statistics are also different depending on where you live. According to CDC data from 2015 to 2018, in these states, Black men are more than 1.8 times more likely to be diagnosed with prostate cancer. And in these states, Black men are more than 2.5 times more likely to die from prostate cancer compared to white men. These differences by race and place are unacceptable. Even if your best clinical practices treat patients equally, this is not enough to eliminate racial disparities in prostate cancer. Given the different barriers that different groups face as they try to prevent, find, treat, and survive prostate cancer, the same solutions won't work for everyone. Instead of equality, equity ensures that everyone gets what they need to have a fair and just opportunity to prevent, find, treat, and survive prostate cancer. To bring equity to how men and their families experience prostate cancer, Zero is meeting the most critical needs of our community in our Black Men's Prostate Cancer Initiative. We are advancing research, providing support, and creating solutions to eliminate the differences for Black men and to reduce the burden of prostate cancer for everyone. That's the goal of Zero. But we need your help. From healthcare providers, we need you to be trustworthy partners to Black men in the healthcare system. From researchers, we need more research on the pathways leading to racial and ethnic disparities in prostate cancer and interventions to address these differences. From policymakers, we need you to develop and implement policies that explicitly target disparities, especially financial barriers to screening and treatment. And from all 3 groups, we need more open and honest conversations about racism in the healthcare delivery system and strategies to eliminate it. Visit us online to learn how we can all work together to create prostate cancer health equity at zerocancer.org.
So who is working on health equity at Zero? So you've already met me, Reggie Tucker-Seeley, Vice President of Health Equity. Our team also includes Chris Bennett, who's our Director of Health Equity, Community Organizing and Engagement, Michaela Duwadne, who's our Manager for Health Equity, and we also have a Health Equity Task Force that includes prostate cancer survivors, prostate cancer healthcare providers, and also researchers and other community members. Our work on the Health Equity team primarily focuses on answering 2 key questions. The first question is, what does an equitable cancer care delivery system look like? And what are the things that we need to do to create that? Our second question is, how do we prepare Black men to expect and get equity as we are navigating the healthcare delivery system? That is, what tools are needed? So you may have heard the saying, a rising tide lifts all boats. That's not a favorite saying of mine. I generally will say instead that you may have heard this saying during the COVID-19 pandemic, we're all in the same storm, We're not necessarily all in the same boat. So we need some help in getting our boats ready for that storm. And so policies and programs that focus on the least vulnerable, policies and programs that focus on the most vulnerable of us are the ones that will have the greatest impact and help all of us, not just those that are most impacted. So what do we do on the health equity team? So one thing is thought leadership. So serving on national boards, making sure we are elevating and amplifying a focus on prostate cancer disparities. We convene and collaborate with our partners to bring together groups to talk about what are the issues that racial and ethnic minority groups are faced when they're navigating their prostate cancer journey, and what are some solutions. We work with our policy and advocacy team to advocate for policies that focus on eliminating disparities in prostate cancer. And we do education and outreach by partnering with our patient programs team and putting out educational materials. So I introduced the framework of the Healthy People 2020. We also have a framework here at Zero for addressing disparities. And our plan is to follow this framework that starts with first defining terms. So terms like health disparities and health equity might be new to a lot of folks. So we want to start with getting alignment on how we define those terms. Selecting health outcomes, because as you saw in that continuum from prevention through detection, diagnosis, treatment, survivorship, end-of-life care, there's a range of things for us to focus on. And so we're a small team, so trying to figure out where do we focus? And then where do we get the data to figure out where the disparities are? How do we measure those differences? And then how do we communicate those differences to various communities? And then how do we evaluate our efforts? And across this process, the importance of partnering with folks in the community who either have already been doing this work or are interested in doing more of it. So we at Zero started with defining terms. And so this is how we define health disparities. And disparities are differences between groups in health outcomes related to preventing, detecting, treating, and surviving prostate cancer. What are some examples of those? Those are racial and ethnic differences in screening behaviors, racial and ethnic differences in treatment, place-based differences in quality of care received, or socioeconomic differences in quality of life after treatment. Those are just some examples of what health disparities are. And how do we define health equity at Zero? Health equity means that everyone has a fair and just opportunity to prevent, find, treat, and survive prostate cancer. But in order to do that, we have to remove obstacles to a usual source of healthcare and coordinated high-quality specialty care, and ensuring that families have the resources they need to manage their health and navigate the primary and specialty care delivery system. So where are we in implementing this framework? Well, as you heard, we've defined the terms, and we're in the process of selecting what our health outcomes are. And we're also working to develop partnerships and also in presenting Zero as a trustworthy partner to the community. And so in doing those efforts, that requires a lot of education and awareness. So that's what we're focusing on as well. And you'll notice that there's a source there, and that source is a paper that I wrote with some colleagues focused on health equity for older adults that also describes the framework. So there are some challenges to creating health equity. And the biggest challenge is that most Americans just aren't aware that health disparities exist. The other challenge is most don't understand what causes them, and most of us do not necessarily find them to be unfair. Now, finding them to be unfair is the cornerstone of the perception of inequity, because that then facilitates action. There was a survey about around 2009 that showed that people were aware of differences by class. So that is this notion that health is different between rich people and poor people, but people were less aware of racial differences. And most people who were aware of the racial differences attributed those differences to individual behaviors. Now, recall when we talked about the social determinants of health, the social context helps to create what our individual behaviors are. So if their social context is different by groups, that can also influence one's individual behaviors. Now, what are some recommendations for addressing health disparities and efforts to achieve health equity? Well, first of all, you're doing it by listening to events like this, like our Health Equity Symposium, learning that these types of disparities exist, and then talking about them and working towards eliminating those differences. Also participating in research. clinical trials, community-based surveys, ensuring that that research has a diverse group of people that are participating so that we hear from multiple voices, and also for clinical trials, ensuring that those drugs are evaluated across a range of racial and ethnic groups. And then talking within your families about health generally and about prostate health and screening specifically. Now, this will be familiar from the video that we just showed, sort of what can providers or researchers or healthcare delivery systems or community-based organizations do? Well, one is being explicit about defining terms. So what is the disparity that's being addressed? And two, we've been talking about these disparities for a long time. I entered the public health field about 20 years ago, and we were talking about these disparities back then. So we need to move past just describing them to intervening, including evaluation. And then that means more work on understanding what is the pathway? Why do we see these differences? And being explicit about the history of our policies that have led to the different things like sorting us into different neighborhoods that then influence our health behavior, that then influences the healthcare that we receive. Center the patient experience and voice in research and policy. Patients know about the healthcare delivery system because they're having to navigate it. So it's important that researchers center the patient voice and think and act at multiple levels. This can be challenging because oftentimes it's really hard to think at the level of the individual, of our neighborhoods or our communities, of our, the big healthcare systems, and then also the level at which policy happens. And lastly, to our policymakers, fund research that focuses on intervening on disparities, develop and implement policy that explicitly targets eliminating disparities. So this doesn't mean policies that just focus on the general population, while those are really helpful. Getting back to my comment about a rising tide lifts all boats. But again, the better saying is, we're all in the same storm, but we don't necessarily are all in the same boats. So it's important that policy targets the most vulnerable among us, because if we help the most vulnerable, then we all benefit. Develop and implement policy so that a cancer diagnosis is not financially toxic to the household. So when you're diagnosed with cancer, when you're navigating the healthcare delivery system, that should not increase your risk for financial ruin. And then eliminate financial barriers to screening and treatment. So here's in conclusion, I read this quote. I've been reading this quote probably for the last 10 years that I've been doing talks on prostate cancer, or on cancer disparities, and on financial hardship, and on survivorship. And the quote goes, "Despite the success on the cancer treatment front, we have done little in a concerted and well-planned fashion to investigate and address the problems of survivors. It is as if we have invented sophisticated techniques to save people from drowning, but once they've been pulled from the water, we leave them on the dock to cough and splutter on their own in the belief that we have done all that we can." And that's a quote from Dr. Fitzhugh Mullen, who is a physician, survivor of cancer, and the founding president of the National Coalition for Cancer Survivorship. And one of our primary goals here at Zero is to make sure that no one goes through their prostate cancer journey alone. So when you're on the dock, we want to make sure that we are there with you. So here's my contact information. If you have any questions about the health equity work that we're doing at Zero, please feel free to email me at reggie@zerocancer.org, or our health equity team at healthequity@zero.org. Thank you. So our next section focuses on racial disparities in prostate cancer. And our presenter for this session is Dr. Kelvin A. Moses. He's an associate professor of urologic surgery at Vanderbilt University Medical Center, director of the Comprehensive Prostate Cancer Clinic, and also a member of Zero's board of directors and our Health Equity Task Force. Dr. Moses' work focuses on addressing health disparities in urologic cancers, determining the role of health literacy and patient interactions with the healthcare system, and optimal care for patients with metastatic and/or castrate-resistant prostate cancer. I always learn something new when I hear from Dr. Moses, and we're so happy that he is able to present today on racial disparities in prostate cancer. Here is Dr. Moses.
Hello, I am Dr. Kelvin Moses, Associate Professor of Urology at Vanderbilt University Medical Center. I want to welcome you to the Zero Health Equity Symposium. I'll be speaking today about cancer disparities with an emphasis on prostate cancer and talk about some of the historical context, some of the current challenges and myths that we deal with in the medical system. I have no disclosures to report. So let's start with the basics. What is a disparity? And the Cambridge Dictionary defines that as a lack of equality or similarity, especially in a way that is not fair. And while we know that life is not fair, we would like to have our healthcare as fair as possible for all populations. And when it comes to health disparities, that is actually very specifically defined as population-specific differences in the presence of disease, health outcomes, or access to health. And a lot of our talk will go over some of the issues that each one of these describes: disease, outcomes, and access. So if you take away anything from this talk, some of the themes that we'll discuss: number one, racial disparities in cancer and in health overall don't occur in a vacuum. And that means that it just does not just occur in the clinic or in the hospital. Racial disparities will not go away if we ignore them. So I know there's a lot of people who wonder why we're still talking about this, or if we keep talking about it, then that just increases racism. And it's really the opposite. If we don't discuss these things, if we don't come up with strategies to fix these challenges, then it will never get better. And lastly, race in itself is not a risk factor, nor is it really a biological entity. Race is a risk in terms of how the health system interacts with patients. However, it is not an inherent defect that causes disparities that we see in health. So just briefly, I want to look at cancer incidence in men. You can see the top two lines. Black men have always had higher incidence compared to white men and have always had worse survival. So these are death rates. And you can see a decline over time, and a lot of that is due to decline in prostate cancer deaths. However, there is a significant gap between Black men and white men. And if you look at all cancers in 5-year survival, Black or African American have a 7% increased risk of death compared to whites in this country, which translates to hundreds of thousands of lives over many years. And so why do health disparities exist? And it's because they're supposed to. It's the way that our American system has been created and perpetuated over time. And so this is the part where I'll talk a little bit about the history, particularly how it has to do with our medical system. So in the pre-Civil War era, the majority of Blacks were enslaved and were really given just the minimum amount of care to maintain productivity, but it was always less than the care given to whites. And commonly, once healthcare outstripped the usefulness of an enslaved person, it was actually withdrawn. And many people were sold off as test subjects for medical experimentation, or their bodies were sold to medical facilities for experimentation or cadaver studies. And the medical profession played right along with the prevailing attitudes of that time. Just one example shown here is Dr. Samuel Cartwright, who was a professor at the University of Louisiana. And in his medical textbook, he theorized that Blacks should be medically treated differently because they are non-human. And he prescribed beatings and all kinds of torture, essentially, to rid African Americans of their drapetomania, which was runaway madness, or dysesthesia ethiopica, which is basically disobedience. And he would actually prescribe that other slaves should beat the slaves so that it gives an example to the others to not perform or not display such attitudes. Another example, very famous, J. Marion Sims, who's known as the father of modern gynecology. He purchased several women and performed multiple surgeries without anesthesia in his experiments on vesicovaginal fistula repair. And this is a very famous painting that formerly hung in one of our medical museums here in the United States. Some of these women were operated on 20, 30 times to the point of extreme pain, infection, and eventually death. As we saw over the last couple of years, there's been an effort to get rid of statues and honorariums to people who performed heinous acts. And this statue of Dr. Sims was removed from Central Park just last year. So some of the mythology that is perpetuated by this era in our history is the persistent Black pain mythology. And it continues to this day. And a study that was done at one of the hospitals I did my residency in 2000 showed that Black patients with broken extremities were less likely to receive painkillers when they went to the emergency room. In a survey of medical students and lay people in Charlottesville, Virginia, people concluded that Black people had less sensitive nerve endings and thicker skin. And that plays into some of the thoughts of how Blacks are treated when they enter the medical system. It also creates a cultural memory among the African American population. There's a very strong sentiment that going to the doctor will expose you to non-consensual experimentation. Your pain will not be addressed. Or even admitting or discussing your illness may cause you to lose your job or lose your worthiness to society. And many men and women will feel if they are no longer virile or fertile, do not deserve care, and some may feel like they are not worthy of care. So if we go to the next era in American history, which is after the Civil War, Emancipation and Reconstruction, it's still a segregated society, and even in hospitals, Blacks were not allowed to use those facilities in the North or the South. And I bring up that point because everybody wants to point to the South and how backwards it can be, but the North participated just as thoroughly as the South did. And also Blacks were excluded from medical and nursing schools. And so many of them created their own schools established by the Freedmen's Bureau. Most of those hospitals went away over time, but there are examples of those hospitals all over the country. They did have unequal and separate facilities, and they were created for the sort of undesirable populations. But because there was some increased access to healthcare, even if it was less than standard, there was improvement in health status among Blacks in this country. This period ended with the institution of Jim Crow laws. And at that point, there was severe restriction to access to healthcare and in general, severe restriction in general society to the movement and freedom of Blacks in this country. Because of this exclusion and segregation, Black physicians and nurses actually created the National Medical Association, which exists to this day, and of which I am a member. And their goal was to improve health outcomes for African Americans in this country and increase access to healthcare for vulnerable populations. So after Reconstruction, you had the Supreme Court decision, Plessy versus Ferguson, which in writing said separate but equal, but in fact established separate and unequal institutions in all aspects of life. And the medical establishment fully embraced this. And so facilities that served patients, if they existed at all, were clearly substandard. You continue to have medical experimentation, the famous of which, of course, is the Tuskegee syphilis study. But there are several others, and I'll mention some of them a little bit down the road. Blacks continue to establish their own medical schools and hospitals, and again, some of which still exist in some form or another, again, to combat the exclusion in facilities for medical care. But this time was also rife with violence in the post-Reconstruction era. And there are several examples of this, but the most famous would be the Tulsa Massacre or Black Wall Street. A prosperous African-American district was burned, many were killed, and there were even private aircraft that were mobilized to drop firebombs over this area. And I bring that up because I remember in the news at 9/11, they said it was the first time that an aerial terrorist attack had occurred on American soil. And I would counter that it had happened, 90 years before. $32 million in damage was caused by this. The Rosewood Massacre in Florida, similarly, several Blacks were killed, Black-owned businesses were destroyed, and many were displaced. And again, here the several $1 million of damage. There was a settlement paid by the state of Florida to some of the survivors in 1994. So again, in this era, you had the Supreme Court decision Brown versus Board of Education, which ostensibly led to desegregation, but really in this time you had heightened segregation of spheres of society. You had resurgence of violence and Confederate imagery. And any efforts that were created to remediate the exclusion of African Americans have been systematically dismantled. In 1968, you had the signing of the Civil Rights Act. And this allowed, you had the Civil Rights Act in 68 and the Voting Rights Act in 1965. Ostensibly, this was created to eliminate discrimination in housing, education. But really, since that time, you've seen an persistence or even increase in disparities in cancer, diabetes, hypertension, many other medical conditions. A lot of that is because we have underrepresentation of African Americans among physicians, nurses, mid-level providers. And then there's also disparities in access to care, insurance coverage, and then even just in receipt of appropriate treatment for particular diseases. I mentioned before the Tuskegee experiment, but there are so many others, and maybe not everybody knows exactly what they are, but again, there's this cultural memory and this cultural mythology that derives from this. Dow Chemical injected prisoners at the Holmesburg prison in Philadelphia with various pathogens just to see what they would do. And just recently, Philadelphia paid a substantial, they admitted to this and paid a substantial amount to survivors or families of these prisoners. Margaret Sanger, who is famous or infamous, however you fall along the lines of the creation of Planned Parenthood, but she really was a eugenicist, meaning that she felt that the mentally challenged, the psychiatrically challenged, undesirable populations should be either euthanized or at least sterilized so that they could not procreate. And even more recently, one of the early chairs of neurosurgery at the University of Mississippi would remove portion of Black boys' brains who had been placed in institutions because of quote unquote behavior problems. They had just been kicked out of school for minor transgressions. And there's a building named after him on their campus. One of the more famous programs, it was a North Carolina eugenics program. And I bring up North Carolina because there's a lot of data, but there are actually several states, who over several decades sterilized thousands of men and women. You would even have social workers who would go out and find find people who were identified as unsavory. And this program was designed to breed them out. In 2014, state legislatures paid out $10 million in compensation to survivors. And while, again, this may seem like a long time ago, number one, I was born during this time, but two, the past is present. Here you can see over the last, or during the prior administration, immigrants who were detained at ICE centers were receiving hysterectomies, again, probably non-consensual without any medical documentation as to the need for this. And so these things are still happening, and we must remain vigilant and knowledgeable about it. So again, going back to cultural memory, we now have centuries of medical so-called experts who are publishing and discussing the idea that Black persons are somehow not human enough to receive consensual and proper care. Because of segregation and its ripple effect over time, you have the exclusion of people of color and women from the medical field, particularly in area or levels of leadership, which then devalues input from those particular groups. And really, we have a propagation of the stereotypes of certain groups over time. And what we've done then is attribute the outcomes and disparities to personal failings rather than systemic inequities that are built into the system. And lastly, what we've seen over and over again is that speaking out against the norm can be met with verbal, psychological, or even physical threats to your health, to your career, or even to your life. So I want to pivot a little bit to cancer disparities, and I will focus on prostate here in a second. But really the beginning of cancer disparities goes back to the early 20th century when cancer was almost uniformly fatal no matter who you were. But it was perceived as a disease of civilization and culture, mostly because cancer is a disease of older populations. And medical societies did encourage discussion about it, but it wasn't viewed, cancer was not viewed as an important topic among Blacks because they're perceived to be victims of or vectors of infectious disease or violence far more than cancer. And so this is really the beginning of the screening disparity. And it took a surgeon named Dr. LaSalle Lafall, who was the former chair of surgery at Howard University. He was also the first Black president of both the American Cancer Society and the American College of Surgeons. And he published a very important paper in the journal Cancer in 1973, looking at the increase of cancer mortality among Blacks in the mid-century. And among his conclusions, he showed that genetic factors alone cannot explain the rapidly diverging trend over this time period. And remember that I told you the Cancer Society started talking about screening and discussion of cancer in the 30s and 40s. So you're already seeing a divergent pattern. Now, he hypothesized that it was an environmental effect, which is not a bad idea because Blacks typically lived in segregated neighborhoods, typically had poor sanitation, typically were located closer to, say, water supplies or power plants or things of that nature. So not a bad idea as far as his conclusion. As we have seen in history, though, whenever a prominent African-American publishes something that criticizes the outcome or the consequences of racism and segregation, there's always a response. And so the American Cancer Society, under the direction of Dr. Herbert Seidman, published a paper just 3 years later looking at cancer among Black and Whites. They did see that cancer was diagnosed at a more favorable stage in whites, and white survival tended to be better even within stages. So people with stage 2 cancer, if you're white, you live longer than a Black person. And so they also showed that equivalent results could be achieved, particularly in cervical cancer, if it was diagnosed at a localized stage. However, their conclusion, which should have been that we should improve screening for cancer and improve treatment or focus on better treatment among African Americans, their conclusion was clearly controlling cancer is more difficult in Blacks than in whites. And again, this is now the definitive statement from the American Cancer Society. And so physicians will now believe this, right? They'll say, oh, it's more difficult. And so that will excuse the poor outcomes rather than focusing on improving treatments. The American Cancer Society did come back with a similar study in a larger group of patients in 2004. And again, this is where that 7% increase in risk of death. But again, in this time, they said the differences in cancer between groups are unlikely to be based on cancer biology, but rather differences in treatment, stage and presentation, and mortality from other diseases. And the last statement here is really important. These differences should be the primary targets of research and interventions designed to reduce disparities. And so, as I'll talk about at the end of the talk, we really should go beyond the research and really start looking at interventions. So screening makes a difference. Again, before screening tests were commonly available, cancer was almost uniformly fatal. However, but since screening tests have been established in our society, you've actually seen widening differences in death. That includes breast, prostate, cervix, and colorectal cancer. Treatment also makes a difference. In several different cancer types, it's been shown that African Americans are less likely to receive appropriate treatment. We can see here in colorectal cancer. We see in breast cancer, Black women are actually less likely to be diagnosed with breast cancer, but actually more likely to die from breast cancer. They're significantly less likely to receive treatment, even when matched for stage, have a longer time from diagnosis to treatment, and lower receipt of chemotherapy after surgery. And this is seen in lung cancer, it's seen in thyroid cancer, it's even seen in blood cancers. And so it's not just that there's differences in stage or presentation, but truly a difference in treatment. So pivoting to prostate cancer, I think this group knows pretty well the statistics, but Black men have more than twice the risk of death from prostate cancer and are typically diagnosed with more aggressive disease, but are less likely to receive definitive therapy, including surgery versus radiation. And I'll go over some studies that show this. Black men are also less likely to receive screening for prostate cancer, and as I mentioned before, receive radiation or no treatment at all. In a study that I did several years ago with a group, including Dr. Willie Underwood, we looked at a large group of men and just looked at the likelihood of receiving any type of therapy for prostate cancer. And we looked at it by their risk level. And you can see outlined in blue there, African American. So this is in comparison to white population, and a number closer to 1 means that the treatment is similar to what white patients receive. And as you can see, for a low risk is 0.81. So that means 19% less likely to receive treatment with low risk disease. That number, next number, 0.74, that means that Black men with intermediate risk disease are 26% less likely to receive treatment. And then at high risk, you see that number 0.62. So that means that Black men with high risk disease are 38%, almost 40% less likely to receive treatment. So really, with escalating risk of disease, you're even less likely or declining odds of receiving treatment. And it really should be the other way around. And we see a little bit of that in Hispanic men, not necessarily for low risk, but for intermediate and high risk disease, still less likely to receive care. And when we looked at it in specific treatments, again, you can see a lot of these numbers are less than 1, except for radiation, which is where it says RT. And then same for Hispanic men, less likely to receive surgery or brachytherapy. Same thing is seen in breast cancer. And sometimes people ask, well, if it's access to care and maybe if patients are insured or highly educated, they'll have equal outcome. But here you can see in women with lung cancer with more than 12 years of education, so high school graduates, Black women are 26% more likely to die from lung cancer compared to non-Hispanic women. Same thing is seen in Black men with prostate cancer. Black men who have 17 plus years of education, so that means they have a college degree and some professional degree, have higher prostate cancer death risk than a white man with less than a high school education. So it's not just about education, it's not just about insurance. There is something in the system that is leading to poorer outcomes in African American men and women. And really, if we take a broader view, we're seeing this in other populations. So as I mentioned, Hispanic men are having worse outcomes, and this will be exacerbated as that population increases. Native American and Alaska Natives have greater mortality to incidence ratio for almost every cancer. And again, it's most pronounced in the screen-detected cancers. And among LGBT populations, there's disparate rates of breast cancer, HPV, which can lead to penile and cervical cancer. And a lot of that has to do with, number one, there are laws that specifically exclude or discriminate against LGBT. There's fear of coming out to a physician or going to a religiously affiliated hospital. And there's pressure to conform to gender expectations, even if you do not fall within neat categories. And so I want to emphasize again, though, race is not a medical entity. It is a social construct. Now, we use it as a surrogate for status in our society, geographic origin, culture, based on our norms that we set in society. However, there's a lot of people who want to focus on the genetic basis of prostate cancer disparity, and it's perfectly reasonable to discuss that. But it makes sense if you focus on genetic aspect of monogenetic diseases. So sickle cell or cystic fibrosis are a clear association with a single gene. However, we're seeing disparities in almost every cancer. And so you either have to conclude that underrepresented populations are genetically inferior, or there are systematic issues that are negatively impacting patients who are not represented in medicine. So why are we talking about this? Why is it taking so long? Why haven't we gotten to equality or equity? And again, if you look at a timeline of our history, that green line is really when we've been quote unquote free, right? Where everybody who is an American citizen can vote, can participate in society. And another way of looking at it, at least in my family, my generation is the first ones who have been fully American citizens since birth, right? So, because my parents were born before the Civil Rights Act, before the Voting Rights Act. And so we're really a young country when it comes down to truly being a democracy. And again, wherever you fall along the spectrum, democracy is under question or under attack in certain corners of our society. There's structural inequity in every sphere. So again, what we're seeing in medicine is the same thing we see in residential redlining, where neighborhoods are undervalued, which decreases wealth among African American and other communities, which decreases their access to good schools, to good hospitals. There are significant actions, namely among the Supreme Court, but in every state where there's restriction of voting rights, where again, you're not able to vote for the representative who could advocate for your needs. There's inequities in police violence and judicial sentencing. And all of this ends up as a greater risk of bankruptcy among the poor and communities of color. So the elimination of disparities is extremely important. Number one, healthcare is a right for all citizens, and especially in a society that is as wealthy as America is overall. It's a hallmark of a just and humane society, and actually makes sense economically. Dr. Paul Farmer, who was at Harvard University, a health economist, stated that it's actually very expensive to give bad medical care to poor people in a rich country. And what that means is that we spend so much on the back end of taking care of people with either severe disease or emergencies, when if we gave preventive care up front, if we had medical coverage on the front end, we could actually reduce our expenditures on healthcare and actually provide better care overall. So what are some things that are being done? The chair of urology at UCLA, Dr. Mark Litwin, went to the California legislature to get funding for free prostate cancer treatment in men who had little or no health insurance. And it actually was found to be more cost effective than relying on safety net facilities. We do have the Affordable Care Act, and despite efforts to get rid of it or lessen its impact, it has insured nearly 30 million Americans to date. And in states that have participated in Medicare exchanges, along with the ACA, you're actually seeing improved screening, increased survival. Medicine is moving from fee-for-service, or basically paying your money and getting a service, to quality metrics. And so that means that physicians who provide low quality care will either have to answer for their actions or see a reduction in their reimbursements. And lastly, advocacy groups are fighting to increase knowledge about health disparities and action. And this is where I'll shout out Dr. Reggie Tucker-Seeley and the entire Zero group for creating the Health Disparities Task Force and having this particular symposium. That task force is working on advocacy with the legislature, with funding for research, for patient education, and also providing resources for patients who are lower income. So I think a lot of people have seen this picture, but we're trying to move beyond equality and really into equity or justice. So we need to provide the tools to provide care for our patients in the highest quality and in the appropriate way. And this is important because, as Dr. Martin Luther King said, of all forms of inequity, injustice, healthcare is the most shocking and inhumane. And we should be moving forward as a society to provide good health care, not just in prostate cancer, but overall, because we want to be a just society. For those who want to read more in depth about some of the issues that are brought up in this talk, here are some books that have come out recently that describe in detail some of the things that impact our medical system. Thank you for your attention and enjoy the rest of the symposium. Thank you very much.
Where you live plays a significant role in how healthy you are. Given the history of racial segregation in this country and all of the policies that Dr. Moses talked about, and how racially segregated our neighborhoods are today, that is especially true when it comes to racial and ethnic minority men, as well as men in poor neighborhoods for their prostate cancer journeys. Our next session highlights the role of the neighborhood environment on prostate cancer risk. I'm honored that we have Dr. Mindy Hebert-Durand to present on this topic. Welcome, Dr. Hebert-Durand.
Hi, good morning.
So Dr. Hebert-Durand is a research scientist in the Department of Epidemiology and Biostatistics in the UCSF School of Medicine. Her ongoing research efforts are focused on cancer prevention and control and address inequities in cancer outcomes due to multi-level determinants, especially structural and social determinants of health. And now, Dr. Mindy Hebert-Durand.
Hi, thank you, Dr. Tucker-Seeley, for inviting me to speak here today with Zero Cancer. I'm thankful today for the opportunity to share with you work from my group, the Dream Lab at University of California, San Francisco, to understand neighborhoods as social determinants of prostate cancer outcomes. I'll start by providing some context for understanding neighborhoods as social determinants of cancer outcomes, and particularly how research on neighborhoods factors into our understanding of racial inequities in cancer outcomes. Then I'll review some of the research our group has done to characterize neighborhoods for research studies and to understand how they impact cancer. There is now a growing understanding of how burdens of disease can differ by place, where someone lives, works, or plays. However, efforts to prevent or reduce disease burdens still tend to focus on individuals. Our work is centered in the understanding that individuals are intimately connected to place, and that places impact their health risks through toxic exposures, behaviors, and experiences. As stated by Tanya Aguirre-Collins from the National Cancer Institute in a 2019 article, health disparities are generally embedded in social or structural determinants of health, which cannot be effectively addressed at the individual level alone. Efforts to reduce disparities and promote health equity must therefore address the dynamic interplay of multiple levels of influence to be effective. This quote relates back to a framework for understanding factors that impact cancer disparities that emphasizes how characteristics related to individuals, their immediate neighborhoods, their states and other municipalities, and the larger social and political context in which they live all come together to give rise to cancer disparities. This framework names explicitly examples at each level of influence, from social conditions and policies to individuals, genetic makeup, and biological responses. The crux of it, though, shown by this long vertical arrow, is about how these levels of influence interact with each other. What that means is that each level impacts other levels, and that this adds up to a complex interplay of factors that impact cancer inequities. Our lab focuses on work that reflects the full span of this model. Today, though, I will focus on work in prostate cancer that emphasizes the neighborhood environment and fundamental causes. I'll start with our efforts to characterize neighborhood environments. In 2015, we published an academic review summarizing research that examines specific features of built and social environments, excuse me, and presented hypotheses for how these features impact cancer outcomes across the cancer continuum, from prevention, risk, and diagnosis to treatment, survivorship, and mortality. We viewed the neighborhood built environment as features that define the physical space or physical environment, street connectivity, the food environment, population density, housing, commuting patterns, parks, traffic density, and recreation. We recognize the neighborhood's social environment as several components, including the racial ethnic composition of a neighborhood, social capital among individuals who live in the neighborhood, socioeconomic status, safety, displacement and gentrification, ethnic enclaves, and segregation. This graphic puts several of our lab's prostate cancer studies in the context of the multi-level framework and shows how those studies span different levels of that framework in order to understand cancer inequities. Excuse me. A few of these studies are available for review as published articles listed here. If anyone wants a copy of any of these articles, feel free to reach out and I can share. One of these published studies is focused on characterizing neighborhoods with a large collection of measures that describe different aspects of the neighborhood built-in social environment. We used a statistical method called latent class analysis that identifies combinations of characteristics of built-in social environments and their interactions with each other to distinguish between meaningful but distinct types of neighborhoods. This table shows the different types of neighborhoods that surfaced in this process. The rows show 9 different neighborhood types, like upper middle class suburb, new urban pedestrian, or city pioneer neighborhoods. Each is named based on some of its defining features. The columns show different groups of features that define those neighborhoods. For each type, text in the cells shows the characteristics of that type of neighborhood. For example, 2 neighborhood types are the suburban pioneer and city pioneer neighborhoods. These neighborhood types are both located in cities, but not in central downtown, have racially and ethnically diverse populations, and lots of mixes of commercial and residential land use. But they are different in that suburban pioneer neighborhoods have more families and more homeowners, and city pioneer neighborhoods have more older residents, single residents, female-headed households, and renters. We characterized neighborhoods across California according to these 9 neighborhood types. Neighborhoods here are defined as census tracts, which on average have about 4,000 residents. One example of how this map extends our understanding of neighborhoods is that it's able to distinguish, for example, between 2 types of neighborhoods we refer to as Hispanic enclaves, neighborhoods with a higher proportion of residents of Hispanic ethnicity who speak Spanish as a first language. 2 types of neighborhoods with large Hispanic populations are distinguished by, among other things, being in urban and rural settings. Inner city neighborhoods in blue and rural neighborhoods we refer to as Hispanic small towns in pink. When we look closer at urban areas, we can see that within the urban space, we have characterized several types of neighborhoods, and with distance from urban centers, several types of suburban spaces. With this work, we examined survival of prostate cancer using the California Cancer Registry. For populations defined by race and ethnicity, we see differences in survival from prostate cancer across neighborhood types. But because these archetypes encompass a large collection of neighborhood characteristics, we can tease apart those specific features of neighborhoods that may impact mortality risk from prostate cancer. For example, the worst mortality outcomes were within inner city and Hispanic small town neighborhood types, which share less healthy food environments. And the only neighborhoods with higher mortality risk for Black compared to white men were predominantly white, middle, and upper class neighborhood types, which to some might seem a little paradoxical, but for us indicated that there might be aspects of structural racism in those predominantly white, middle, and upper class neighborhood types that conferred worse outcomes for African American men. And that observation leads into a study that is currently ongoing and for which I'll share some preliminary results. The RESPOND study is an integrated set of studies, 4 in total, all focused on a common theme of identifying the multi-level determinants and characteristics of aggressive prostate cancer and disparate mortality among African American men. It's the largest study of prostate cancer among African American men that's been conducted in the United States. This study works with a hypothesis that multiple social stressors at both the individual and the contextual level, including structural and social determinants of health, impact individuals' experiences of stress, and that this experience of stress is reflected in the body by processes that aggravate prostate cancer and increase a man's risk of dying from prostate cancer. 2 of the neighborhood level social stressors we are studying are structural determinants of health, contemporary redlining, and racial bias in mortgage lending. Contemporary redlining is the odds of denial of a mortgage application in a specific neighborhood, typically census tracts. Racial bias in mortgage lending is the odds of denial of a mortgage for an African American applicant compared to a white applicant in a given neighborhood. Both measures compare neighborhoods to the surrounding metro area. They're scaled indices that reflect whether a neighborhood is more or less likely than the surrounding area to experience redlining or racial bias in lending. And an important point is that these measures are adjust for or controlled for sex and loan-to-income ratio, meaning that the loan-to-income ratio, a measure of whether or not a mortgage is safe to lend, is not factoring into these biases that these measures are indicating. The RESPOND study is based across 6 states plus Detroit. These maps show how neighborhoods in these regions fit on the redlining index using data from mortgage applications around 2010. And so that focuses on a specific point that this is not historical redlining that we oftentimes see in the news. These are not HELOC maps from the 1950s or 60s or later. This is contemporary redlining. These are denial of mortgages in 2010. And the darker pink areas show neighborhoods more likely to be denied a mortgage, and those lighter areas are least likely to be denied a mortgage. This graph shows how African American and white men in the RESPOND study reside across neighborhoods defined by redlining. It shows that African American men are more likely to reside in neighborhoods where mortgages are denied. White men are more likely to reside in neighborhoods where mortgages are granted. Looking at the same distribution across regions in the RESPOND study, and just looking at areas most likely to receive a mortgage, we see that African American men are less likely to live in those areas where mortgages are granted across the regions. This difference ranges from 26% in Louisiana and Texas to 63% in Detroit. And now this graph shows how prostate cancer mortality risk differs across levels of redlining for African American and white men in 3 of the 6 regions. The vertical axis shows increased risk of mortality from bottom to top. Redlining, or denial of a mortgage, increases from left to right, indicated by the triangles. 2 main observations emerge. The first is that at equivalent levels of redlining, we see that African American men are more at risk of mortality, which shows that redlining doesn't account, doesn't account for all of the racial disparity in prostate cancer mortality. The second observation is that we detect increases in mortality with increasing denial of mortgages. This trend differs by region and by race as we look across regions, as you can see comparing California to Georgia and Louisiana. and so indicates differing impact or differing processes of structural inequities across these regions. Moving on to racial bias in mortgage lending, these maps show the second measure. Dark pink regions are more likely to have racial disparity in mortgage denial. African American men are more likely to live in areas with less racial bias in lending. Stated another way, white men are more likely to live in neighborhoods with mortgage lending bias against African American men. And this is a figure showing mortality risk analogous to that I showed you for redlining, where racial bias in lending increases from left to right. In the case of bias in mortgage lending, patterns in mortality across lending bias were generally very similar. So I'm showing results from just one region, Georgia. And what we see is that mortality does not differ across levels of racial bias. This shows that our measures are distinguishing different processes of structural inequity. They are not just reflecting that mortality risk differs across neighborhoods, but that risk differs across these measures of lending bias and structural racism. Ongoing work for this study in our lab is testing whether these measures of structural racism impact prostate cancer mortality among African American men through the neighborhood built and social environment. Work in other companion projects that are part of the RESPOND study additionally test whether social stressors are linked to prostate tumor genetics and tumor inflammation. More broadly, work in the field of place and health increasingly considers a few things: a life course perspective, that is how neighborhoods impact health during important periods like the perinatal period, adolescence, and older adulthood. Another is resident-generated data or crowdsourced data on how people experience their neighborhoods on a daily basis using mobile applications. Another considers neighborhoods where we live with where we work. So the neighborhood where we live is very important to our health, and it is considerably more difficult to measure how the neighborhoods where we work or where we play or that we travel through affect our health. And so continuing work is looking into these areas. And finally, acknowledging and uplifting aspects of neighborhood that offer tangible benefits are important to consider, especially as we translate our research findings to interventions to improve the neighborhood environment. With all of these efforts, we remember that the goal is to understand how neighborhoods can be supported and invested in to improve health and eliminate health disparities. I want to finish up with some concluding thoughts. Equitable research of healthcare services, prevention, therapy, clinical trials, requires a multi-level approach, which is supported by the research I've shown you today. Not just outreaching to individuals, but acknowledging that individuals can be supported or constrained by their neighborhood surroundings. The second is that understanding cancer biology and how tumors grow and develop requires recognition that structural and social determinants of health not only influence our risk for cancer, but the biology of the tumors. And finally, lasting intervention to eliminate cancer disparities will address multi-level, not just individual risk factors. This last point can feel daunting because it requires structural changes, including and beyond the healthcare system. But it's not impossible, and it's important, so it's a worthy pursuit. Finally, I want to acknowledge the members of the Dream Lab at UCSF. The Dream Lab is led by faculty Scarlett Lynn Gomez, Iona Chang, and Salma Sharif Marco, with a near army of analysts, interviewers, project coordinators, project managers, and biostatisticians. And then on the right, I've listed others that we've collaborated with for some of the studies that I showed you. And I'm happy to address any questions or to receive communication. I have my email address here and my Twitter handle.
Thank you so much, Dr. Herbert-Durand. I do have a question. Given your results that showed different patterns in different places, does that suggest that perhaps the interventions need to be developed locally? That is, we need to understand more about those local contexts in order to think through the ways in which we intervene to address the disparities that you described.
Yes. So, the US is a huge country with a shared history, but also these regions, these states have their own individual histories as well. And I think two important things pop up. One is that the history of residential segregation differs in different parts of the country. All parts have experienced racial segregation and still do, but the processes by which racial segregation was executed may have occurred differently in different areas with different results. So I'm recalling a passage from Doug Macy's book on American apartheid, that the spatial distribution of segregation in the South differs from other areas of the US based on the history of slavery in the South compared to other parts of the US. And even though what we're measuring here is contemporary redlining, I think it's important to note that contemporary redlining is a legacy of historical redlining. And even though it's happening differently, the results in the neighborhoods are a little bit are not the same across the country. And I think that leads into exactly what you suggested, that there may be federal policies, there may be that can address some of the policies that perpetuate structural racism and segregation, but that also there needs to be work at the regional and local level, because there will be differences between these regions. Absolutely.
Yeah. So we have to do that thing, which oftentimes is really hard for us, which is two things at once and thinking at multiple levels. So we have to think about, the federal level sort of policies that we need to address, but also how those policies were actually implemented at the local level may look different, which then suggests that the intervention at the local level may look different if you're doing it in one region versus another. Great. Well, Dr. Herbert-Durand, thank you so much for this presentation. When I saw your paper on the neighborhood environment and risk for prostate cancer, I knew I had to reach out to you and Dr. Gomez. So thank you both. Thank you so much for presenting. Thank Dr. Gomez and all the work that you all are doing in the Dream Lab. And we look forward to staying connected here at Zero.
Thank you for having me.
Thank you. And now I'm proud to announce Zero's Health Equity Advocacy Award. Congratulations to Representative LaShawn K. Ford of Illinois. Zero recognizes Representative Ford for his work in Illinois to remove financial barriers for men seeking prostate cancer screenings. I had the honor of speaking with Representative Ford about this award. And you can see that presentation at zerocancer.org/HE Symposium, SYMPOSIUM. We're announcing other awards later in today's symposium, but first it's time for a quick break. We'll be back at 10 a.m. Pacific time and 1 p.m. Eastern for those of you on the East Coast with a session on prostate cancer and cardiovascular disease. And you don't want to miss our discussion with our 3 filmmakers later today who are on a mission to raise awareness about prostate cancer within the Black community. And then also later today, we have a session where you'll be able to ask doctors anything. So please get those questions ready so that you'll be able to submit those. So our Zero's second annual Health Equity Symposium continues in just a few minutes. Thank you. Hello, and welcome back to Zero's second annual Health Equity Symposium. I want to first thank you all so much for joining us today. I hope you are learning as much as I'm learning about health disparities, the history of health disparities, place-based disparities. And so thank you so much for spending your Saturday here with us today, if you're here with us live, and thanks so much for watching at a later date and sharing these videos with your respective networks. I'm Dr. Reggie Tucker-Seeley, Zero's Vice President of Health Equity. And coming up, we have a session on health equity and cardiovascular disease. And that will be presented by Dr. Avi Guha. And Dr. Guha is the inaugural director of cardio-oncology at the Medical College of Georgia. Dr. Guha is a rising star in the field of cardio-oncology with the recent American Heart Association Strategically Focused Research Network grant in disparities in cardio-oncology. And now the presentation by Dr. Guha on prostate cancer and cardiovascular disease.
Good morning. My name is Avirup Guha. I'm the Director of Cardio-Oncology at Georgia Cancer Center. I would like to thank Zero for inviting me to present on the topic prostate cancer and cardiovascular disease. Thank you, Reggie, for the kind introduction. Today we cover the following topics. Are men with prostate cancer at a higher risk of cardiovascular disease? Are Black men with prostate cancer at a higher risk than white men with prostate cancer for developing cardiovascular disease? What is the role of chronic toxic stress in cardiovascular disease amongst men with prostate cancer? How can cardiovascular disease and prostate cancer be mitigated? We will get started with our first topic. Here is a slide deck presented from the Radical PC1 study, which enrolled patients from 5 different countries, where 2,600 men with prostate cancer were consecutively enrolled with a mean age of 68 years. 8.2% of patients had metastatic prostate cancer. It's interesting to note that 22% of these patients had known cardiovascular disease, and 99% of these patients had uncontrolled risk factors. The risk factor studies here are obesity, which 90 to 95% patients had, hypertension control, which suboptimal control was noted in 75% of the patients, hyperlipidemia control, 50% of the patients, both with CVD and no CVD, had poor control. And the other risk factors studied were activity level and smoking. 57% of the patients, both in combined CVD and non-CVD, had poor global risk factor control. This is a summary of data from the SEER dataset, where patients with various cancers were followed over a period of 10 years. It is interesting to note that all cancers, when they get far enough from cancer diagnosis, have a high likelihood of dying from heart disease. Specifically, in terms of prostate cancer, as shown by the figure on the bottom right here, cardiovascular disease mortality at 10 years higher than prostate cancer mortality. So what is the CVD prevalence in men with prostate cancer? Here I have put in data from patients who are from the US national cohort of non-cancer standard population, and it is seen that stroke, coronary heart disease, and heart failure are seen in 2.6%, 8.3%, and 2.5% of all males when you look at the period of 2015 to 2018. Amongst non-Hispanic Black males, the percentage of stroke, coronary heart disease, and heart failure are 4.1%, 6.7%, and 3.6% respectively. The prevalence in cardiovascular disease amongst men with prostate cancer with androgen deprivation therapy is somewhat similar in terms of stroke and coronary heart disease compared to the general male population. Among those without androgen deprivation therapy, the rate of stroke and coronary heart disease is actually lower than the general population. Let's study a little bit about androgen deprivation therapy and how that increases cardiovascular disease. Androgen deprivation therapy is a group of various medicines, and on the left side of the figure, here we show the hypothalamic pituitary hormonal axis of how testosterone is generated and how that has effect on prostate cancer through the androgen receptors. The various medications have been introduced to reduce the activity of this axis, to reduce the total testosterone load on the prostate cancer, thus acting as treatment for prostate cancer. The most commonly used medications, which are referred to as androgen deprivation therapy, are GnRH agonists, leuprolide, goserelin, triptorelin, and hystrelin. The less common group of medications also referred to as androgen deprivation therapy is GnRH antagonists, degarelix and relugolix. And then other medications used through various pathways to reduce testosterone activity on prostate cancer are androgen biosynthesis inhibitors, abiraterone acetate, and second generation androgen receptor inhibitors such as enzalutamide, apalutamide, and darolutamide. The effect of combination of ADT plus any of these medications or ADT alone has been seen on effect of muscle, which leads to sarcopenia and decreased exercise tolerance. In terms of numbers, lean body mass reduction is seen in 5% of the patient, and fat mass at the subcutaneous tissue level is seen in about 10% of the patients. In terms of cardiometabolic health, androgen deprivation therapy causes dyslipidemia, diabetes, and central adiposity. It's noted that LDL increases in about 7.3% of the patient, triglycerides increase in 26.5% of the patient, and diabetes worsens in 60% of the patients. In terms of hypertension, it is noted that hypertension increases about 20% of the patients, and high-grade hypertension is seen in about 6.9% of the patients. So why is CVD noted to be lower in men with prostate cancer? Androgen deprivation therapy increases risk in the first 6 months, and those that survive prostate cancer, the risk goes to baseline. Lower risk is noted at lower stages. However, as we get up in the stages of cancer, this difference disappears. Also, it is interesting to note that patients entering registries are more likely to undergo routine screening for early detection of prostate cancer. Hence, they are noted to be at lower stages. Also, those are the same patients who are more likely to engage in healthcare systems for preventive cardiovascular care. In general, if you are unable to enter the denominator of the population because of lack of access to such registries, then it's likely going to show the outcomes as we showed earlier. This is exemplified with this meta-analysis of randomized controlled trials looking at CVD mortality amongst various RTOG trials. It is seen that the relative risk of mortality, CVD mortality with GnRH agonists is insignificant for CVD death upon metallizing these 8 studies. There has been recent discussion about the role of the different types of androgen deprivation therapy and the cardioprotective nature. Here are 2 studies which have been heavily talked about. The PRONOUNCE study, which studied degarelix versus leuprolide. And the study, even though it was stopped prematurely, adjudicated MACE, and it was noted that patients with degarelix compared to leuprolide at 15 versus 11 events in the follow-up period, the hazard ratio was not significant in this relatively smaller study. The HERO study, which was a randomized controlled trial published in New England Journal of Medicine, which followed patients for all of the 48 weeks of follow-up and compared relugolix versus leuprolide, showed that the hazard ratio for cardiovascular events at 48 weeks for relugolix was statistically significant at 0.46. In fact, 3.6% of the patients in the relugolix group had cardiovascular events, and 17.8% of patients receiving leuprolide had cardiovascular events. This led to the recommendation by the International Cardio-Oncology Society, which said that GnRH antagonists should be considered in patients with pre-existing symptomatic coronary artery disease who require androgen deprivation therapy at a level of evidence 2AB. A new phase 3 randomized open-label clinical study, the REPLACE-CV study to assess the risk of MACE associated with relugolix comparing with leuprolide, is ongoing right now. Androgen pathway inhibitors, like we saw earlier, also have known cardiovascular events. For example, abiraterone and enzalutamide have been associated with hypertension. Abiraterone and enzalutamide have also been associated with fluid retention and edema. So in summary, cardiovascular risk factors are high and uncontrolled in men with prostate cancer with as high as 90% obese. Cardiovascular disease affects 20 to 25% patients with prostate cancer. CVD is the largest cause of mortality at 10 years from prostate cancer. Men with prostate cancer have an increased risk of CVD due to androgen deprivation therapy in the first 6 months. GnRH antagonist versus agonist story is to be told yet. Prostate cancer survivors in epidemiological studies tend to have lower cardiovascular disease prevalence after the 6 months of survival, perhaps since screening and detection of prostate cancer is also select for those who screen and control CVD risk factors. With that, we move on to our next topic: if black men with prostate cancer are at a higher risk than white men with prostate cancer for developing cardiovascular disease. Here is a map of mortality from prostate cancer presented across the United States. The age-adjusted mortality for 2000 population from the years 2015 to 2019 was 18.9 per 100,000. Here we see a trend of mortality spread across the different states. As you know, Georgia, where I'm located, has mortality between 21.8 to 24.1 per 100,000. However, the mortality for Black men with prostate cancer is 37.9 per 100,000 in the United States. In fact, if you look at the mortality for Black men due to prostate cancer, the mortality for Black men is almost 49 per 100,000 in the southeastern states, including Georgia, where I'm located. Here we see a table which shows the leading cause of death among non-Hispanic Black and white men. And the number one cause is heart disease. Number two is cancer, not specifically prostate cancer. And it's seen that there is significant disparity in death rate due to both causes in non-Hispanic Black versus non-Hispanic white men. Here we explore the cardiovascular mortality in non-Hispanic Black men. This data was a little difficult to find, and we only have two studies to present here. The first study was a study done by colleagues where they combined data from VA, SEER, and radiation therapy cohorts, where they defined overall mortality, cancer-specific mortality, and other cause of mortality. Here I present the other cause of mortality in a fine and gray model, fully weighted. There's 30% increase in other cause of mortality in Black men compared to white men with prostate cancer. The other cause of mortality likely includes cardiovascular mortality. However, it is not just cardiovascular mortality. In a study which looked at only cardiovascular disease mortality, and this study combined data from Massachusetts and Pennsylvania, and they studied data from 2000 to 2015 and presented data with 4-year time points: 2000 to 2003, 2004 to 2007, 2008 to 2011, and 2012 to 2015. And it was noted that the racial disparities in cardiovascular mortality has widened over time, and this is comparing African Americans to Caucasian men. It was noted that there's an increasing trend in cardiovascular mortality in the Pennsylvania area compared to and not present in Massachusetts. However, these increasing trends of cardiovascular disease in Black men compared to white men was seen only in localized disease, but not in metastatic disease. What about cardiovascular risk factors? There's no race-specific data and regarding what happens to risk factor after starting ADT. However, there was a study done by colleagues from the VA cohort where they included 90,000 US veterans with prostate cancer, of which 32.7% were non-Hispanic Blacks. 68.1% received comprehensive CVD risk factor assessment, and 54.1% were noted to have uncontrolled risk factors. Of these 54.1%, 29.6% were not receiving risk-reducing medications. However, if you see on the figure on the right here, over a period of time, this trend has improved, and risk reduction techniques have improved over time from 2010 to 2017. What is interesting to note was when they did a risk adjusted analysis for reasons for lack of comprehensive risk factor assessment, white men were less likely to get a comprehensive risk factor assessment compared to non-white men. The real details was in the supplements, where I saw that amongst those who were excluded, which is 2,197 patients who did not end up in the analysis, there were a fair bit of Black men who never got any screening done, mainly because they didn't even have a primary care visit. So in summary, cardiovascular disease mortality is higher in Black men compared to white men. Data from southern states need to be looked at further. No data regarding cardiovascular disease incidence is presented based on race. CVD risk assessment is poor across races, even in systems with equitable healthcare such as the VA hospital. Difference in CVD mortality, as noted in Pennsylvania, may be related to social determinants of health and associated with chronic toxic stress. Now we'll study the role of chronic toxic stress in cardiovascular disease among men with prostate cancer. Social determinants of health, which we see in this figure over here, which includes educational status, access to care, neighborhood metrics, relationship metrics, and socioeconomic levels, which includes family income and personal income. The same paper which looked at the difference in cardiovascular effects because of race also looked at neighborhood socioeconomic position. In this paper, they defined neighborhood socioeconomic position as census-level tract measure, which included poverty, median family income, households with female head percentage, proportion of income coming from rent, proportion of whites, proportion of blacks, proportion of unemployment, proportion of male employment, proportion of patients receiving welfare assistance, and the joint race income index of concentrations of extreme. Further, since Massachusetts and Pennsylvania had different geographic areas, they used a unique metric using the Environmental System Research Institute's data to calculate the distance traveled by men to come to the healthcare system using ArcMap. What they see is cardiovascular specific mortality is high in those who are on the 5th quintile of NCEP, which is highest level of disparities compared to the 1st quintile of NCEP. And this has persisted at a high level from 2000 to 2015. On the figure over here, it is noted that neighborhood socioeconomic position contributes to cardiovascular disease in men with prostate cancer more in Pennsylvania compared to Massachusetts. However, overall, it's high across the years and has maintained the numbers as we talked about. We'll talk a little bit about what is allostatic load. So allostatic load or chronic toxic stress is because of environmental stressors, major life events, and trauma and abuse. Let's put it into perspective for prostate cancer. Prostate cancer patients have a major life event, which is prostate cancer. I consider androgen deprivation therapy as a major life event because it's a new chemical introduced into their system. They have adverse socioeconomic position or social determinants of health for various reasons, which includes work, home, and neighborhood environment. And lifelong trauma and abuse can lead to this adversity as well. These different levels of adversity in social determinants of health leads to individual level adaptations, which is called allostasis. Allostasis is the action of the autonomic nervous system, the hypothalamic pituitary adrenal axis, the cardiovascular, metabolic, and immune systems to protect the body to these internal and external stresses. The price of this accommodation to the stress can be measured as what is called allostatic load. This is the usual wear and tear that results from chronic overactivity or underactivity of the allostatic systems as mentioned above. Here is an adaptive model. Allostatic systems respond to stress. So this is where stress happens. And we see this in the upper panel over here. And it initiates the adaptive response and sustains it until the stress ceases, which is the plateau over here. And then after the stress is over, the allostatic system shut down and we see recovery. Allostatic responses are initiated, which is seen in the lower panel over here, by increase in circulating catecholamines from the autonomic nervous system, glucocorticoids from the adrenal cortex. This sets into motion adaptive processes that alter the structure and function of a variety of cells and tissues. These processes are initiated through intracellular receptors for steroid hormones, plasma membrane receptors, and second messenger receptors for catecholamines. The crosstalk between catecholamines and glucocorticoid receptors signaling can occur. The top panel on the figure in the middle shows the normal allostatic response. The different glucocorticoid level and catecholamine level go up, and then after the stress is over, they plateau and then they go down. Over here, we see the effect of repeated stress. These are the 4 conditions which are noted. Number 1, from repeat stress, from multiple stresses. The second level, where there is lack of adaptation to different types of stress. Prolonged response, or patients who have stress but there is no recovery. and inadequate response that leads to compensatory hyperactivity of other mediators. For example, inadequate secretion of glucocorticoids resulting in increased concentration of cytokines that are counter-regulated by glucocorticoids, which leads to a pro-inflammatory milieu. How do we measure this? There's various different markers of measuring allostatic load. Generally, in literature, allostatic load can be measured by these 11 markers, and it's a yes and no answer. Systolic blood pressure greater than 140, diastolic blood pressure greater than 90, heart rate greater than 100, total cholesterol greater than 240, HDL less than 50, triglycerides greater than 150, hemoglobin A1C or marker of diabetes greater than 6.5, obesity or BMI greater than 30, glucose levels greater than 110, C-reactive proteins greater than 3, and interleukin 6, which is an inflammatory marker, greater than 1.8 picogram per ml. Here we study the role of allostatic load in men with prostate cancer and the racial differences. We studied a cohort out of Cleveland, which had 7,168 men with prostate cancer. The use of androgen deprivation therapy was noted to be about 20.9%. A lot of these patients had radiotherapy at 31.9%, and chemotherapy was performed in 4.2%. Only a few of these patients were metastatic prostate cancer at 6.2%. It was noted that 1,570 patients were non-Hispanic blacks, and 1,498 patients received androgen deprivation therapy. During the 1-year time point prior to prostate cancer diagnosis to after the prostate cancer diagnosis, the addition of androgen deprivation therapy led to increase in allostatic load across both races. In fact, the pre-prostate cancer allostatic load was noted to be 2 across the board, except in non-Hispanic black men, where it was 3. The median was 3, and over a period of 1 year, the allostatic load went up. So the increase was 0.14 in all the patients, and it was higher in non-Hispanic white patients compared to non-Hispanic black patients, but this difference wasn't statistically significant. What was interesting to note that pre-cancer levels of chronic stress and non-ADT related increase in allostatic load was higher in non-Hispanic black men, which may explain the racial difference in ADT-related CVD. And Woodit was studied in another paper where we studied the effect of allostatic load on CVD after prostate cancer, which is being presented at this American Heart Association meeting. Here we had 5,261 patients with prostate cancer who had subsequent follow-up for at least 2 years, or if they died during the 2 years period. 6.6% of these patients had a 2-year MACE. For every 1 point increase in allostatic load prior to prostate cancer diagnosis, the risk of major adverse cardiovascular events increased 25%. In fact, this remains significant across the various different individual events, which included heart failure, ischemic stroke, acute coronary syndrome, and atrial fibrillation. For allostatic load calculated 2 months, 6 months, and a year after prostate cancer diagnosis, the MACE rates remain somewhat similar, and it remained uniform across the board with different types of MACE, as we note on the bottom right corner. So in summary, differences in CVD mortality, as noted in Pennsylvania, is related to social determinants of health and associated with chronic toxic stress. Chronic toxic stress or allostatic load is higher in non-Hispanic black men coming into prostate cancer and increases during prostate cancer treatment with androgen deprivation therapy. CVD events in men with prostate cancer are related to that increased chronic toxic stress or allostatic load. Next, we study the role of various things we could do to mitigate this risk for cardiovascular disease. I only have one slide where we go over the ABCDE algorithm. A is awareness of heart disease. All the things we talked about androgen deprivation therapy can do, what are the risks associated with prostate cancer development and prostate cancer medications, is a part of the awareness which I provide to all my cancer patients. Use of aspirin is recommended in men with prostate cancer as a preventive measure for primary prevention of cardiovascular disease. To pay special attention to certain anti-cancer medications used in men with prostate cancer, which can cause certain arrhythmias due to prolongation of one of the EKG intervals called QT. B stands for blood pressure management, and the goal blood pressure being less than 130/80, and to follow biomarkers in men with prostate cancer, which include cardiac specific biomarkers outside of the PSA, which is troponin and brain natriuretic peptide. C stands for three things. Smoking cessation, as we know, is a big risk factor and risk factor management technique, which helps in management of cardiovascular disease. Cholesterol control or lipid management using statins, and we are gathering data regarding use of calcium scoring of chest CT scans done in men with prostate cancer and its use in risk stratifying men starting androgen deprivation therapy. D stands for three things, which is diet, diabetes, and drug choice. Diet specifically follows the American Heart Association Heart Healthy Diet. Diabetes, we look for diabetes in men with prostate cancer and then look forward to controlling the diabetes using various medications, including metformin. And the drug choice, and here's where the story regarding agonist versus antagonist is going to be clarified over the next few years. But currently, the drug choice lays with intense prostate cancer treatment versus just an ADT-based backbone, where the risks are different. E stands for exercise, EKG, and exposure, where I recommend American Heart Association's Life's Essential 8 related exercise treatment, which is 30 minutes a day, 5 days a week, as a prescription to all my men with prostate cancer, regardless of their physical activity status. And we slowly go up to 30 minutes a day, 5 days a week, starting from 1 minute a day. The EKG and exposure are related to the A's, where EKG at baseline is recommended with men with prostate cancer starting treatment to get a QT measurement, which is the interval which can prolong because of cancer medications. And exposure is relevant to the length of treatment with androgen deprivation therapy. It is known that longer they get treated with androgen deprivation therapy, more is the damage to the vasculature and increase in vascular risk. It is important to consider that current risk stratification algorithms were determined using data that had less than 5% non-Hispanic Black men with prostate cancer and did not consider any social determinants of health or allostatic load. New risk stratification algorithm and preventive measures are needed to make this algorithm better. With that, I have my overall summary where we see that cardiovascular disease and prostate cancer is a complex topic. Radical PC1 upon completion will give nice epidemiological insights. Risk factors plus androgen deprivation therapy is responsible for additional cardiovascular disease events beyond the age expected cardiovascular disease. There is significant variable and unanswered questions about racial differences in cardiovascular disease in men with prostate cancer. The difference in cardiovascular disease due to race is due to increased allostatic load or chronic toxic stress affecting non-Hispanic Black men more than non-Hispanic white men. Use of ABCD algorithm to mitigate cardiovascular disease risk in men with prostate cancer, especially those starting ADT, is strongly recommended. And with that, I would like to thank Zero for inviting me for this presentation. Here I have a picture of my daughter who just turned 1, and we celebrated her birthday just last week.
Great. Well, thank you so much, Dr. Guha, for that presentation. And so I'm realizing that for many of our listeners, the field of cardio oncology might be new, and some of the things that you presented in terms of, as prostate cancer patients are navigating care, this notion that pre-diagnosis stress has an impact on cardiovascular outcomes.
Yes, that is what we are finding, and it was very interesting to actually look forward to that research because it had never been done before. In fact, if you saw the research coming into it, it was very scarce. I mean, I thought I could just make a presentation from the state of Georgia and data from it, and I didn't find anything, so I had to zoom out and look in the United States. So I think there's a lot of research to be done, but I think that effect of chronic toxic stress was definitely something very stark, even in one institution's cohort, which included a lot of Northeast Ohio.
Mm-hmm, mm-hmm. And then sort of the treatment that people get as they're navigating prostate cancer treatment can also then influence cardiovascular risk factors. So how should patients sort of think about, the treatments that they select, and then the impact that that could have on cardiovascular events as they're navigating care.
I think the ABCDE algorithm still stands true. I think the first contact with healthcare, I think, is very important. I mean, the initial approach of screening for prostate cancer, getting diagnosed with prostate cancer, getting quick care, and to have cardio-oncology involved and on board along with our urology and medical oncology colleagues in treatment decisions and risk factor management, and prescribing the appropriate medications such as statin, aspirin, etc., generally ends with a good prognosis. Although there's research going on in this space, but I would imagine that if equitable care is provided from the cardiovascular standpoint, I think regardless of someone's race, we can mitigate risk factors and control prostate cancer and cardiovascular disease associated with it.
Something else that I found really interesting was at the beginning of your presentation, you mentioned how highly prevalent cardiovascular risk factors were. And so given how prevalent those risk factors are, is that something that, patients should be, talking to their oncologist about as they're navigating treatment, that is getting or ensuring that there is some cardio-oncology sort of consultations going on there to make sure that, both of those conditions are being managed?
Yes, and I think this is very dependent on the part of the country you're in or part of the world you're located, because what happened is for so many years, cardiology and oncology were separate fields. Very recently, since 2009, since International Cardio-Oncology Society has existed, the fields have slowly started coming together, and really in the middle of the previous decade is where everything came together. So I think there's slow uptake in various parts of the country, but I would say it is very important for prostate cancer patients, and I enable my patients more than enable the field itself, is to, if you have any pre-existing conditions, maybe cardiac, maybe non-cardiac, bring it to attention of medical oncologists. It might be very relevant to mitigate some of those issues before your treatment starts.
Mm-hmm. Well, and two, my last question is about that ABCDE sort of framework and sort of, things that patients should be aware of. But honestly, that's a lot to put on patients who are navigating care. So is this something that, all oncologists or all cardio-oncologists are aware of and that they bring to the clinical encounter? Or what is the stage of sort of ensuring that, patients know about it, but especially that providers know about it?
I think that's the reason why our specialty has almost taken off, I would say, because there's so many survivors. In fact, by 2040, we're expecting 25 million of all types of cancer survivors. I bet a lot of them are prostate cancer survivors because of how well our medical oncology colleagues have done. I, in my clinic, have a framework which we follow, and it is written like that. I go over it with my patients, but I don't think so it's commonplace. I would imagine a cardiology clinic where somebody comes in with prostate cancer, they're talking a lot about the heart. And in medical oncology clinic, they're talking a lot about the cancer. So a lot of the overlap clinics are slowly coming up. I think most academic medical centers have it. Some non-academic big institutions also have cardio-oncology care. I'm hoping more for it, but most of us who are working in the space definitely go over all these details.
Okay. Well, one thing that I didn't mention to our listeners is that Dr. Guha is a member of our Health Equity Task Force here at Zero, and we're so glad to have his input on our team, because we are eager to raise awareness around these issues at the intersection of cardiology and oncology. So Dr. Guha, thank you so much for presenting today at our Health Equity Symposium, and we look forward to continuing our conversation.
Thank you so much for the invitation.
So our next presentation is going to focus on clinical trials. Historically, Black people are underrepresented in clinical trials. According to a 2016 report by the FDA, African Americans make up only 7% of clinical trial participants. Racial and ethnic and age diversity in clinical trial participation is critical to understanding the safety and efficacy of treatment options for men with prostate cancer. And now we're going to hear from an expert in this space, Dr. Hella Borno, who is an assistant professor of medicine, a practicing medical oncologist, and a health equity researcher at the University of California, San Francisco. Now I'll turn it over to Dr. Borno.
Hi, everyone. My name is Dr. Hella Borno. I'm an assistant professor of medicine at the University of California, San Francisco. I practice clinically, treating primarily advanced prostate cancer at the Helen Diller Family Comprehensive Cancer Center as a medical oncologist. I'm also the CEO and co-founder of Trial Library, a public benefit company in clinical trial access. Today, I'm delighted to be invited to speak with you on equity in clinical trials, and we're going to be focusing on prostate cancer. These are my disclosures. So first, we're going to talk about the epidemiology of prostate cancer. We'll review the background on inequity in clinical trials. We'll go into definitions, including understanding recruitment science, as well as gatekeepers, outlining barriers in clinical trial recruitment, and then closing with evidence-based strategies to promote equity. So first, let's think about prostate cancer on a population level. We recognize this is a very large burden of disease in the United States, and that 1 out of 8 men will be diagnosed with prostate cancer during their lifetime. But this disease does not impact us all equally. We know that in the United States, Black men have the highest incidence and cancer-specific mortality associated with prostate cancer. In fact, 112 per 100,000 men across all races are impacted by prostate cancer, but we see the highest incidence here among Black men at 183 per 100,000. When we look at mortality across all races, about 19 per 100,000 men are dying of this disease, and we see that 38 per 100,000 men of Black racial ethnic background are dying from this disease. So clearly, prostate cancer has inequities in whom is impacted and dying from this condition. Given that, how are we doing in terms of clinical trials? We know that there are a variety of canonical clinical trials that inform our standard of care. And I want to first think about in the localized disease setting. The localized disease setting, the PROTECT trial provided level 1 evidence that there was no difference in prostate cancer-specific mortality among patients who received radical prostatectomy, radiotherapy, and active surveillance at 10-year follow-up for low risks, Gleason 6, or intermediate risk, Gleason 7 prostate cancer. But yet, when you look at the composition of participants in the PROTECT trial, you can see that actually less than 1% of this international trial were of African or Caribbean descent. How can we make valid conclusions about active surveillance in the context of these demographics among study participants? Now, shifting to the advanced disease context, Dan Spratt and colleagues summarized the enrollment of Black men in castrate-resistant prostate cancer. And they looked at 7 landmark phase 3 randomized controlled trials that led to the FDA approval of 5 new therapeutic options in the CRPC setting. And when they looked at these data, they found that among 7,250 men that enrolled in these clinical trials, only about 3.3% of them were Black men. This clearly demonstrates consistent inequities in whom prostate cancer clinical trials are serving in the localized early disease setting as well as the advanced disease setting. When we look across all tumor types, clinical trials lack representation. Here you see 2 bar graphs. On the left side, you have the percentage of US population that are by race ethnicity, baby blue being non-Hispanic white, African American being in dark blue, and then orange being Hispanic or Latinx origin. When you look at the bar graph on the right, you see the percent of participants in cancer clinical trials. And if we were achieving representation in clinical trials, these would be mirroring each other. The composition and the breakdown of patients in the United States would match the composition and the breakdown we see in our clinical trials. But what you can quickly tell here is that, in fact, these do not mirror each other, and the vast majority of participants in cancer clinical trials today are non-Hispanic white. And that's what we saw when we looked at the prostate cancer clinical trials, that we were not achieving representation, and in fact, we're achieving pretty significant underrepresentation. Why is this important? Well, it's important for a variety of reasons. One is the future. If we ensure maximal inclusion clinical trials, then we know we're developing therapeutics that can be safe and effective across populations. 2, we also know that clinical trials have outcomes that are beneficial for patients. Here you see outcomes in pooled clinical trials. There was an increased overall survival in Black patients versus white patients enrolled in pooled trials. This plot here is overall survival. This is time. And Black men had a statistically significant decreased risk of death compared to white men when they were enrolled in metastatic CRPC clinical trials. So this is sort of an equal treatment setting situation, which is a clinical trial. We see that patients do well on clinical trials, and we lose the health inequities that we see on a population level in the clinical trial setting. This is part of the why this is important, that we need to address inequities in whom clinical trials are serving today. So let's think about the science around clinical trial access and clinical trial inequities. It's been long recognized that we have a lot of work to do in clinical trial access. And in 1993, the NIH issued a mandate. It's called the Revitalization Act. It mandated the inclusion of racial ethnic minorities and women in publicly funded clinical trials. But this mandate did not have a process around accountability to make sure that we're actually doing this work. What it did do is it spurred a field of inquiry, and this field is called recruitment science. Recruitment science is an empirical body of studies scientifically evaluating the efficacy of various social, cultural, psychological, technological, and economic means of convincing people, especially members of hard-to-recruit populations, that they want to become and remain human subjects. So a lot of my talk, the rest of my talk will be under the umbrella of recruitment science. So with that, let's think about gatekeepers. Gatekeeping is an activity of controlling and usually limiting general access to something, a function or system that controls access to something. So when we think about clinical trials, and we know we have inequities in clinical trials among men with prostate cancer, who are the gatekeepers? Well, there are a variety of gatekeepers, and we're going to think through that. One key gatekeeper that we recognize is myself, my colleagues, providers. 77% of patients that enroll in a clinical trial do so because their provider recommended it. And while we have a variety of stakeholders involved in our clinical care and involved in offering us a clinical trial, the government, industry, research organizations, the insurance companies, the investigators, the researchers themselves, the healthcare systems. At the end of the day, the provider needs to recommend this. The provider is a bottleneck. These are also different gates. The provider is a key bottleneck, and only about 13% of oncologists in the United States regularly engage in clinical research. We know that this bottleneck is a big driver of inequities in whom clinical trials are serving today. And here we highlight racial ethnic inequities. We also know that there are gender-based inequities in other tumor types. But at the same time, it leads to inefficiency. And so studies are taking quite some time to enroll, and it takes longer for us to access therapeutics that may be beneficial to us. So the recruitment science literature is vast, but I'm going to be pouring into patient and societal factors a little more deeply, thinking about socioeconomic status and insurance, belief and attitudes about clinical research, historical context. I'm going to think more about provider factors. I already mentioned that providers are a key gatekeeper in access in clinical trials. We'll talk about institutional factors, including clinic resources, translation resources, research support, and trial design. The role of DEI prioritization, thinking about eligibility criteria, trial site selection, study materials. The net result of all of these different factors and components is what we have seen, which is unequal access to clinical trials. And this is why we need to think deeply about this in order to advance equity in whom clinical trials serve. So patient and societal factors. We know that there are out-of-pocket costs associated with clinical trial participation, such as travel and lodging. And at Dana-Farber, at MGH, there was a program that was established called the Cancer Care Equity Program. And this program provided financial support to address the out-of-pocket costs associated with clinical trial participation among eligible patients. Patients were eligible if their household income, combined household income, was less than 700% of the HHS federal poverty limit. What you see here is that after the initiation of the Cancer Care Equity Program and the offering of this financial support, there was an acceleration of enrollment to clinical trials at the site. And among recipients of these of this program, of the financial support from this program, you see that they're enriched for being much more likely to be bothered about financial concerns, concerned about travel costs for the trial, concerned about lodging costs, worried about affording their medical costs, afraid about health insurance being inadequate, being worried about being able to adhere to a trial schedule, and worried about transportation to trial center. So it goes to show that these pragmatic concerns were top of mind for patients. My research team and collaborators also implemented a financial reimbursement program at 2 sites, UCSF and USC, which addressed the out-of-pocket costs associated with travel and lodging. And what you see here is the breakdown of the costs that were supported. You can see that a good chunk was associated with lodging support to attend clinical trial visits. Patients also had a variety of other ground transportation needs, such as gas, parking, and others. And there was a subset that had air transportation needs, such as flights. What you can see here from looking at the frequency of reimbursements by the different sites is that there was regional variation between the types of travel support needs that were required. And that what you can imagine is that patients traveling to Southern California may have different needs than patients traveling around the Bay Area, just given the distinct topographies of the 2 sites. Now, when we think about provider factors, I already mentioned a really key learning, which is providers are gatekeepers in clinical trials. But providers have biases. Ethnographers Daniel Dohan and Galen Joseph observed patients at academic medical centers and providers at academic medical centers and started to understand the different attributes that providers were looking for implicitly in order to offer a clinical trial to a patient. They were asking questions like, is this patient proactive? Is this patient meticulous? Do they perceive good communication? Is the patient adherent, embedded in a social network? These are attributes that would lead to a higher likelihood of being offered a clinical trial. And when you step back and think about this, you can see why that might be the case, because the providers are trying to finish their clinical trial. They're trying to get patients that will stay on study. They're trying to have patients that will be perhaps perceived to be easier to manage. These are all biases that are driving systematic exclusion of certain populations in clinical research. We also see that the provider within a health system is coming in with their own beliefs, clinical factors, social behavior, social status, and other perceptions that will influence the way that a provider interprets and synthesizes the information that is delivered to them from a health seeker. So the health seeker's race, ethnicity is digested and processed by the provider based on their own set of biases and lived experience. And that leads to influence of their professional decision-making and the services or treatments being received. And this is really key to just acknowledge, and why initiatives like the Just Ask initiative that was started at Duke can help with some of the barriers in whom clinical trials are serving today. Now, institutional factors are also important to acknowledge. There are structural contributors to cancer clinical trial inequities. It could be related to organizational and climate and clinic resources. For example, are the providers stretched too thin to even discuss clinical trials? Recruitment does tie up clinic exam rooms, and perhaps there's a high volume of patients that need to be serviced. Maybe the clinic is difficult to navigate for the average patient, and that leads to reticence among patients to engage in activities that might require more visits. Perhaps there are long wait times to be seen, which is much more disruptive for a patient's life and leads to further reticence to engage. There may be limitations around research-specific resources. Perhaps multilingual support needs aren't being met with limited translation resources available and materials not being translated in multiple languages. Perhaps trial information dissemination is limited. Maybe most providers within a clinic don't actually even know what trials are going on and have to be reminded, and there aren't simple tools to help them keep up. Navigators may also not be available. Navigators both to offload the providers from doing any heavy lifting associated with implementing a study, but also to help walk the patient through the trial journey and to make it more intuitive. These are all resources which you can imagine vary across different clinical environments and can be a big predictor, if available, can help drive recruitment to clinical trials in a more equitable fashion. Now, research design and analysis is also relevant. I'm going to go through this really quickly, but it is really important to think about intentional design, and making sure researchers are thinking about this even at the clinical trial concept phase. Thinking about the epidemiology of the disease that is going to be included or reflected in the clinical trial, making sure that there's a model to achieve targets around certain representative recruitment goals. Thinking about the research team and the diversity of the research team, thinking hard about eligibility criteria and if certain criteria can lead to systematic exclusion of certain populations, thinking about the role of study procedures and whether any seem like a heavy lift for patients that could lead to patients stepping away from the opportunity, and also reflecting on pragmatic things like study sites and materials and what barriers they can either remove or create. Data analysis, even in the preclinical phase, is relevant. We acknowledge that race is a social construct and not a biological variable. We also recognize that there is genetic variation in ancestry, that genetic variation and ancestry are distinct from race. The role of race in data analysis is to serve as a proxy for social and structural determinants of health. And we know that if we can have diverse patients on trials, we can make more generalizable conclusions. We can generalize the conclusions of the clinical research. We can also identify, based on the data that we use, whether or not we do not have sufficient subset of patients to make valid conclusions about safety and efficacy for all. So given that, I wanted to shift gears and to really round out this conversation with pragmatic approaches to health equity. And there are several pragmatic opportunities to apply an inclusive research approach. And these are things that investigators, providers, and patients can be thinking about. So the infrastructure. Within the clinic, is there a promotion of workforce diversity? Is DEI and cultural humility training part of the requirements for that environment? And is there a focus on making sure that there is readability of consent materials and it's available in gender neutral language and is multilingual? From a clinical trial design perspective, prioritizing DEI in all protocols and concepts is important. Defining diversity research priorities as it relates to various identities and patient clinical factors and being intentional around this is also key. And evaluating eligibility criteria very closely, as some can lead to systematic exclusion in certain populations. One example of this is thinking about things like comorbidities. Comorbidities meaning if a patient has multiple types of health conditions. As you can imagine, a patient that has less access to health care will have more comorbidities that are uncontrolled than patients that have a patient that has less active access to healthcare will have more comorbidities than a patient that has more access to healthcare, and there may be as a result of that, that patient is also going to have less opportunities to engage in clinical trials if they require optimized comorbidities. And so it goes to show eligibility criteria must be scrutinized to think about its cascade impact on diversity and inclusion in clinical trials. Now, trial site selection is also very important. It's important for investigators to evaluate the demographics of patients serviced at study sites, consider incentive models for sites recruiting diverse patient populations. And then lastly, community partnership and engagement. This is so important. Engaging local providers, having an ear on the ground on community needs and being attentive, and then early partnership with patients and advocacy organizations. Now, I bring all this up because I think it's really important that the onus is on the gatekeepers and on the research ecosystems to create a more equitable and inclusive environment for clinical research. I do think it's also important for patients to be empowered with the tools, information, and resources that they need in order to identify clinical trials that may be well suited for them. But I don't think it's the patient's job to do all that homework. It's really up to the system and the providers to transform it such that it is more intuitive and accessible so that patients can be afforded a chance to consider opportunities that may be well suited for them. With that in mind, navigation is a really important piece to health equity. Patient navigation integrated with approaches that address social determinants of health. Social determinants of health are the conditions in which a person lives that influences their health outcomes. We know that navigation plus that type of support can increase clinical trial recruitment, has a larger effect on larger late phase clinical trials. And this model is also primarily in service of more diverse patient populations. Navigation helps and is a huge mechanism for accelerating equity in whom clinical trials serve. The other key piece is genomic testing. We know in clinical trials today, especially in the advanced disease setting, genetic information is very commonly used as part of eligibility information, but yet genomic testing and genetic counseling is not equitably accessed. So this leads to this cascade impact of inequities in clinical trials by virtue of having inequities in whom is receiving genetic testing. There are a variety of resources that can help clinicians, especially in under-resourced settings, counsel patients. And there are a variety of resources for patients that are educational about the role of testing, what the process looks like, how to find a genetic counselor, and to understand the impact of the results. These types of resources can open up access to genetic testing, which by extension can help open up access to clinical trials. Now, I wanted to share this from a piece by Dr. Doan and Joseph, published in The Recruitment Practices and Politics of Inclusion in Cancer Clinical Trials. What they wrote is that given the heterogeneity of clinical trials, research infrastructures in the US healthcare system, the meanings of inclusion in research are multiple, and inclusion by itself does not ensure equity. And it really shares that there's just so much more work to do. So I wanted to close here with these visuals, which is that when we think about equity in clinical trials, we need to understand the differences between these terms. Inequality means unequal access to opportunities. And what you can see here are two beings with unequal access to the opportunity of an apple due to this structural difference that leads to circumstances of advantage for some and disadvantage for others. Equality is about evenly distributed tools and assistance. So here you see that there are evenly distributed tools and assistance, but yet there is still a circumstance of advantage for some and disadvantage for some. Now, when we go to equity, there's the role of custom tools that identify and address inequality. So that's a lot of what I sort of discussed in our conversation today, which are some strategies and tools to promote equity in clinical trials. These customized tools and interventions to promote circumstance of advantage for everyone. But what do we really want? We want to change the structures that lead to circumstances of disadvantage. We want justice, fixing the system to offer equal access to both tools and opportunities. And this is the goal. We have a whole lot of work to do to get here, but this is certainly the goal. We want justice and access to all resources that may be beneficial for the patients that we serve. So with that, I thank you for your attention and your time, and hope that you learned a lot through this conversation. Thank you.
Hello, and welcome to our Zero, the End of Prostate Cancer Health Equity Symposium, Prostate Cancer in the Black Community Film Series discussion panel. My name is Chris Bennett, and I'm the Director of Health Equity, Community Organizing, and Engagement. Before we jump into our discussion, I'd like to introduce our very talented and esteemed panelists. We're joined by Londi Maduro, the director and filmmaker of The Silent Killer, Reggie Hicks, the filmmaker and creator of If You Are My Brothers, and Terrence Afar Anderson, the filmmaker and producer of the film The Black Walnut. Thank you all so much for joining us, and thank you so much for creating these extremely important films. I want to take a second to have the filmmakers actually introduce themselves and give us a brief summary of their works. So Londi, we'll start with you, then we'll pass it off over to Terrence, and then Reggie, we'll have you finish up.
Hello, everyone. I am Londi Maduro, and I did the film The Silent Killer, Prostate Cancer in the African American Community. In our film, we had a gentleman we call our host travel around the United States and follow 4 men at different stages of prostate cancer, as well as interview different scientists, urologists, medical professionals. We held group discussions and really tried to get to the heart of the matter of why African American men are less likely to get tested for prostate cancer, and kind of show why it's important to some of the risk factors and that they're getting prostate cancer at younger ages and at more aggressive forms of disease. So we really tried to get that word out and show that it doesn't matter, what walk of life you come from. We interviewed hip hop moguls and city councilmen and family men and vegans. It really didn't matter. All these men had prostate cancer. So we just really tried to show that it's more about being aware of your health. That's kind of the premise of our film.
And again, my name is Terrence Afar Anderson. I will produce and directed the film The Black Walnut. I have been principally all of my life as an artist. I've been a playwright. I've written over 20 plays. And I've always done work. My work as an artist has been to be of service. And so I wanted to communicate messages. That's what my plays have all been about. But in 2009, I was diagnosed with prostate cancer. Shortly after I was diagnosed, because neither of my brothers had been screened, I recommended that they both be screened, and my eldest brother was in fact diagnosed. And I realized the importance of spreading the word, the message about the importance of being screened for prostate cancer. And I wanted to come up with a device, a tool that I could use that could deliver that message in a very efficient way. Again, I am a playwright. I've produced plays. They've been produced in San Francisco, Las Vegas, and Washington, and so forth. But I wanted to do something that would be more portable, something that could be transported a lot easier than sending an entire theatrical company and cast and crew to different locations. And it just seemed to be a good idea to do a film. The Black Walnut is my first feature-length film. It's been an adventure. It's been a great adventure. It's been a blessing. And I brought my playwriting, my approach to plays, I brought that to bear in producing this film. I wanted to do something that would engage people, something that would have an engaging storyline. And so I produced the film as a docudrama, but a novel docudrama, because there's so many aspects of the prostate cancer disparity impacting African-American men. I decided to create a story that would allow for the inclusion of those different elements, those different components of the disparity. And so it's a fictionalized story, but to really bolster that, I brought in real prostate cancer survivor warriors portraying themselves in the film. So it's a novel docudrama, and it's been received very well, and I feel blessed that it has been received that way.
I'm Reggie Hicks, and I am the producer of If You Are My Brothers. And like Terrence, my background has been in really service, worked in public media, public radio, and public television most of my career. And so I've always been about being involved in projects that can make and will make a difference. Not a filmmaker necessarily, but involved in television a great deal. And never have I, in my wildest dreams, thought I would be a documentarian, because my film is a documentary. It's pretty unique in the sense that I have a fraternity brother of mine who wanted to make sure that his alumni brothers knew about his situation. He was diagnosed with a very aggressive form of prostate cancer and given about 18 months to 2 years to live. And so he put his story out there in an email. As a matter of fact, the documentary, the title of the documentary comes from that email that he sent to us that basically said, if you are my brothers, you will get tested and you will know about this disease and you won't be in the situation that I'm in. And that really had an impact on me. And I immediately said, this story needs to be not just among the brothers that are receiving this email, but really that story needs to hit home with a lot of other brothers outside of our own small network. And so I approached this gentleman. I asked him if he would be willing to share his story beyond just the alumni brothers of our Alpha Phi Alpha chapter. And he said, I'm on board. And we began chronicling his journey with prostate cancer. I guess the twist, if you will, because with every story, there's always a twist. In 2 years into the project, I was diagnosed with prostate cancer. So when we look at the statistics of prostate cancer among African-American men, this particular documentary really just brings that home. I had no clue, no idea I would become part of the story. But like many of us as African-American men or men of color, we don't expect to be part of the prostate cancer story. So this story really becomes one of two individuals, one where I was fortunate enough to be diagnosed early, and then you had another person who was diagnosed with a later stage, more aggressive stage of prostate cancer. And it's our journey, but we're connected through our brotherhood and through our shared experiences. So that's about it in a nutshell.
Thank you all so much for sharing that. I definitely think that's a great segue actually into the first question that I have here for all of you. So if you would all just kind of give us a kind of insight into what your motivation was for using film as a method or platform, if you will, to engage and urge the Black community to have discussions around prostate cancer.
Sure. For me, initially being the only female on this panel, I did not have a motivation to do a film about prostate cancer. But a friend of mine, Chris Edwards, he came to me because at the time, he was like, look, I know I'm high risk for prostate cancer because my father and my brother have prostate cancer and no one's talking about it. Like, if it wasn't for them, I wouldn't have known. And, as he started sharing with me and we started doing research, and I'm like, I'm not hearing anyone talk about it either. So I was like, yes, I'm on board, especially when we learned how it affects African-American men. I was like, I'm on board. And so we started doing the research on the project and really started to learn how it affects African-American men. I was just like, okay, we need to do something. Film seems like the best medium to do that. It's a way to really reach people. And to me, I feel like sometimes it's hard. It's just my perspective as a woman, right? I'm coming as a woman. Mm-hmm. Sometimes it's hard to get men to talk about their health. And when they see it in someone that looks like them, then they start to pay attention. And so that's why it was really important to me to make sure that we had men from different walks of life, like I said, because the excuses I was hearing was, well, if I just eat right, I'm good. Like, why do I got to do that? I don't eat meat. I don't eat barbecue, whatever, right? And we were getting like those kind of excuses. Or I've never heard any, well, I don't know what's causing it. So why should I, get tested? Or my faith will heal me. So why should I go and get a prostate exam? I believe that the Lord will heal me. And so we wanted to make sure that we touched on all those things, and film felt like the best medium to really get that out there, that it doesn't matter. We had men from every walks of life. So we interviewed pastors and they talked about, yeah, you're right, God will heal you, but faith without works is dead. And that's, whatever your religious belief is, just making sure that we were touching on all these things so that there were no more excuses to just get tested, right? Just know what your baseline is and know, take responsibility for your health. And so film just felt like the best medium to do that. Like I said, just to make sure that they were seeing themselves reflected in the faces of the men that we interviewed. And that has definitely worked for us.
Yeah.
If I might add, I touched upon my motivation for doing the film because of my own journey as a prostate cancer survivor warrior, and my having shared that information with my brothers, and then they were both tested. And so that was essentially the motivation for my doing the film. But I got a bit of a reality check not so very long ago. I mentioned that my film featured prostate cancer survivor warriors telling their own stories. And recently, 2 of those men transitioned. They both passed 6 days apart. So that has given me great motivation to do a sequel to The Black Walnut, one that features surviving family members, particularly women, wives, adding their perspective of how their loss that was caused by prostate cancer, that was caused by late stage diagnosis of prostate cancer, how that loss has affected them and their families. So for me, the motivation, particularly with the way that The Black Walnut has been received, is to do a sequel to add a different perspective. And the trailer for the film is basically like a preview. We opened with and it was maybe prophetic, I don't know, because the story was fiction, but we opened with a cemetery scene. And there's a suggestion throughout the trailer that someone has died from prostate cancer, and we're talking about this particular person. But this particular person shows up at the end to suggest, that once you take care of yourself, you don't necessarily need to face that outcome. But now, again, in reflection, having included that as a trailer, and I wrote the trailer before I wrote the script, it just, again, seems a bit prophetic. And with the loss of these 2 friends, there is great motivation to do a sequel and incorporate a much, not more profound, but a very profound angle with people that have experienced the loss of loved ones due to prostate cancer.
Yeah, for me, I think the first initial motivation was Ralph, and that was my frat brother's name, fraternity's brother's name was Ralph Franklin. And I said was because, as Terrence mentioned, after about 6 years of us being around him and having that bond, he passed away. And ironically, the day before he passed, we were actually with him, sort of in I guess, family reunion, if you will, where that was the last time he was with his family. And we initially decided not to go, but we went, and I was just so blessed that we, from his courage, that was another motivation. His courage, he was positive throughout this entire process. He knew that it was important for him as a lawyer. He was always investigating, new treatments, and he was involved in a clinical study. That strength and that him, really putting all of this on the line and being able to share it was my motivation. And then, of course, the second booster in all of this, and the stages in a rocket, right, that really propelled me to say, oh, wow, we have to, this has to be something that we've got to get the word out. Was my being diagnosed was a great motivation in really telling this story. And then when Ralph passed, it became a legacy for him and his courage. And his wife recently passed. So, this was really important to me. And it really led me to making this not only about a documentary, but because of my public broadcasting background, I've been involved in other projects that also had a community outreach part to it. So, in public broadcasting, it's all about extending the shelf life of your project. It's not just about getting it on TV or getting it in theaters. It's about how do we interconnect that particular way that you're getting the message out, which is through a documentary or film, and build community around that. So that was the other motivation for really making this a labor of love, if you will.
Yeah, absolutely. I think, and I know all of you have somewhat touched on this, but the conversation around prostate cancer, particularly in the Black community, is something that is not often discussed within our own community. So what would you all, if there was a point or maybe two major points that you could kind of touch on to address like what the most challenging aspect was about getting the folks to actually talk about their health, and how that kind of contributed to the amazing work that you all have done?
Is it back to me?
I guess so, Londi.
So I would, Londi and Red. Go ahead, Londi.
Oh, I'm sorry. You asked again, what was the...
Yeah, so what would you say are the most challenging, like what were the most challenging aspects of getting folks to actually talk about their health in particular? Yeah.
Well, for us, we toured with the film. So one of the most, and we went to different states, and one of the most challenging aspects, of course, is always funding, trying to get the money to do things like this. Really getting the men out there was definitely difficult. Once we got them there, they were engaged, right? So trying to figure out what's the best way to get them to come out, because sometimes you can be preaching to the choir. You'll have a lot of people who are either prostate cancer survivors, right, or affected by prostate cancer in some way. So they're there to kind of continue to learn more information, but we really want to get people who hadn't even thought about it yet. So that definitely for us had been a challenge, is just, trying to make sure we're, finding venues and getting support to be able to travel to these places, or at least send a movie if one or two of us can't come. And then for us, we always wanted to make sure that we were not just playing this movie, filling everyone's heads, and then leaving them with, okay, now what do I do, right? So trying to make sure we had at least a urologist or some type of medical professional to speak after the film. Definitely, us as advocates, if we could have a prostate cancer survivor so that the men felt like they had someone they could truly connect to, was really important to us. And then also making sure that they had somewhere to go if they needed help, like Zero. Zero has been an awesome champion in supporting us in this. And so always trying to make sure if we could have a Zero representative, or if we were somewhere where we couldn't, that there was some type of way that they could connect through the 360 program, or something that they knew that they weren't getting all this information and then being left empty-handed. And that was super, super important to us, but also a challenge of trying to tie all those things together, is at the end of the day, I am a filmmaker and have other films and projects, right? So still trying to make sure that we could leave them with that support system as we traveled throughout. That was important to us, but also challenging for sure.
Absolutely. Reggie, same question for you, Reggie.
There is some difficulty in telling the story because for me, I open myself up to a lot of things. I mean, exams, the biopsy, and as a man, you kind of got to remember where all of this is happening, right? And my cinematographer was one of my closest friends, and he's probably seen a lot of me that most people other than my wife has seen. And I think from my perspective, I was inspired by Ralph, because Ralph did not care. Ralph was like, I'm having this treatment, whatever you need to film, you need to film. And so I had to let that go. I had to say to myself, and I give you this one story, and then I'll move on. And I thought about, how am I portraying myself? If I'm not open, then how can other men be open, right? And so one of the things that I was always told, a couple of people tell me, oh, the biopsy is horrible. Oh, it hurts. Da, 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 da. You can't. So I'm having this in my mind going into my first biopsy, which is, on camera. But I had to say to myself, I've got to look comfortable. I've got to endure this, and it wasn't bad at all, but I didn't want to have this thing like, oh, I'm tensing up and it's hurting, because I'm saying to myself, I've got to have other men to relax and understand that it's a process, that it's not going to kill you. It can actually save your life. So I think for me, being convincing, it was important. But also, I really realized that, you get as much as other men will tell you. Some men feel comfortable talking about anything. Other men won't go down that incontinence road. They won't go down that ED road. So you take what you can get, and hopefully by telling the whole story, it will make other men, feel comfortable about maybe not putting their information out to the world and everything else for that matter, but having those discussions with family, having those discussions with their partner, being open at that level. So I think that's, you take what you can get, I guess, is at the end of the day.
I love that. I think that's a very strong testament to being vulnerable and how strong that actually makes you. And then Londi, I love the point that you made about, what happens next, right? Like what happens after the diagnosis piece. And I think that's something that I know us at Zero are really working on. Terrence, I do have a question specifically for you. So I know that you had mentioned the docudrama style. What actually made you want to use that style of genre, or kind of genre, for the actual project that you made?
One thing I learned as an artist, as a playwright, is that American consumers like novelty. We like things different. And I just wanted to take a different approach, by having a combination of actors and real prostate cancer survivors. And to backtrack for just a second, the only challenge that I had with my prostate cancer survivors, they were all eager and anxious to tell their stories. But some of them, including the urologists and oncologists, were a little bit camera shy. Okay, so I had to get around that. But the other thing I'd like to note, though, is that as these prostate cancer survivors were telling their stories and the actors heard their stories, there were two of my cast members that had never been screened before, but were screened for prostate cancer. So, and even the process of making the film, that critically important message was delivered. But again, I just wanted to do something a little bit different on that. And I am not bashful about telling people that probably the greatest influence on my writing, other than becoming aware that I was a writer, reading William Cullen Bryant's poem, Thanatopsis. That's when I realized I was a writer. But the greatest influence on my approach to writing, believe it or not, was Rod Serling, The Twilight Zone, because he wrote things to make people think, to make people consider possibilities, to make people feel. And even as a kid and as a young teen, that impressed me tremendously. So that's why I took a novel approach to this particular production.
I love that. So I know that we've somewhat discussed, all of us have somewhat discussed and touched on, like your motivations. But what is one thing that you hope that your film and work can actually do for the audience? What's one thing that you hope that they take away from this?
The theme of the Black Walnut is all of the prostate cancer survivors are being recruited as an army to spread the word about the importance of early detection and to increase awareness of the African-American prostate cancer disparity. So when people see the film, that is what I want them to take away, to be motivated themselves, not necessarily to produce a film, but to be motivated to spread the word, and the very first screening, I completed the film as my culminating strategic initiative from the Robert Wood Johnson Foundation Fellowship. And after the film was completed, the very first screening was for the University of Alabama at Birmingham for a bunch of health educators across the Southeast. And man, they were really truly motivated to go out and continue spreading the word. So that's what I'd like to do, is for the film to recruit an army of advocates of activists to increase awareness of the disparity, as well as the importance of early detection in the African American community.
That's awesome. I would say for me, I didn't mention this, but when 6 months into doing our research on the film, my father was diagnosed with stage 1 prostate cancer, and he agreed to be in the movie. And, you know, because I had been working on the movie, I was able to like arm him with all this information, right, that he could take to his doctor, and he could ask educated questions and be empowered by that and realize, yes, he's been diagnosed with prostate cancer, but it's not necessarily a death sentence, right? And so, you know, when we first hear the word cancer, I don't care who you are, your brain kind of just shuts down. And then it's like, I don't know what else you have to say to me. I just heard you tell me that I have cancer, right? Which is why a lot of times they encourage you to bring someone with you. And so for me, I just know how, you know, my father told me he felt when he was able to ask his doctor questions because he was armed with all that information. And I hope our movie can really help other men do the same. You know, fear comes from the lack of knowing. Right? A lot of men don't want to have the prostate exam. They don't want to have a DRE. They're not sure about a PSA. Like they don't want to do any of these things because they've heard all these horror stories, you know, really to Reggie's point, right? But knowledge is powerful. And when they're armed with that knowledge, or even, you know, we haven't really touched on this, but we know that sometimes their primary care doctors may not be offering them a PSA or a DRE, right? And so to go in there and kind of, like I said, take responsibility for their health, to say, you know, what about this? Well, I'm over 50 or I'm 45, but I know my father had prostate cancer, or grandpa or Uncle Joe or grandpa, you know, grandpa Sam he died of something, and I just learned it was prostate cancer. So maybe I should be getting tested, you know, because these are the things in our culture that we don't talk about. Everybody knows that Uncle so-and-so died of something, but we don't know what it was. And then you learn, wow, all these people in my family have prostate cancer. And then you go to your doctor and they're not testing you for a PSA, or, you know what I mean? And so to arm them with that information, now they can go to their doctors and ask educated questions. And if they're feeling they're not supported, they can decide, well, is this really the right doctor for me? Because we touched a lot in our film about how a lot of people in the African American community have the distrust of physicians and how we can change that. Right. So really, like I said, our goal is to arm men with knowledge so that if they are in this situation, they can ask their doctor educated questions. If they are, you know, over 40, they can start asking about a PSA or a DRE. You don't have to wait for your doctor to offer you these things. You can actually ask, right? I know it don't sound sexy, but you can still do it. So that way you're not hit with something later out of the blue that you had no clue you were even susceptible to. So that's our goal with our film.
Thank you so much, Londi. So many gems. Someone has to tweet that fear comes from the lack of knowing. I think that is a gem, and one that I think everybody here should be talking about. Reggie, same question for you.
Yeah, a couple of things. One of the things I think with this film and what we're trying to do is to move from health awareness to health action. It's one thing to hand somebody a pamphlet, or, you know, to give them a sheet of paper, or even to talk to them about prostate cancer. But I'm hoping with what I'm doing and what the three of us are doing is really, by telling these stories, is to move beyond, again, from health awareness to health action. And I like to use what my wife has coined, life over libido. To get around that. And I think, you know, telling a true story of one person who was diagnosed early, and 12 years later, as I celebrate that anniversary in about 3 or 4 days, and another person who was a lawyer, smart, at the top of his game, diagnosed young, aggressive form of cancer, and is no longer with us as a result. Those two stories, and as Londi mentioned, you know, all of those things about distrust, and how Ralph was almost misdiagnosed. Given, you know, 2 years, he had given up until someone said, you need to get a second opinion. That second opinion led the 4 more years of him being with us, the 4 more years of hope and being with his family and seeing his first grandchild and those kinds of things. So this story plays out. And I will say that as we look to rework the story now to bring it, even so many things have happened and to deal with survivorship, like Terrence mentioned, this is an ongoing story, particularly with me. So as we rework this film now to include survivorship, to include, where we are now in research and all of the things that are available, and organizations like Zero bringing all of this to the attention of men across the country and around the world, moving into this new kind of phase of things. As just one example, I sent the rework outline to my cousin, who is a writer, and her husband is my first cousin, family history of cancer. She read the outline, made her husband go to get his PSA checked, looked back at other PSAs, and they saw it was on the rise. And long story short, he was diagnosed with prostate cancer. Now, his family has 3 of his siblings has passed away from cancer. And so just on reading the story, she was motivated to get him to do something. And I think that is important. I'm here because I was motivated by Ralph's story to do something. And so I tell people all the time, if there's only one person that, this documentary has saved a life, we can start with mine, because I could have easily let it go, PSA, below 2, I'm getting older, no big deal. But we pressed on, I pressed on, and my physician team did as well. And I was diagnosed early enough to still be here and tell the story.
So I think we definitely recognize that this is a very unique platform and kind of vehicle to move this message across to the masses. What would you all say? It's a question for all of you. What kind of advice would you give to someone who's interested in using film or just any other unorthodox kind of platform to advance health equity and awareness of prostate cancer? And to Reggie, I love that point that you made to kind of get folks to move from the health awareness point to the health action piece.
Yeah, you want me to go? I can go first this time.
Go ahead, Reggie.
No, you know what? Because it's real simple. Tell the story, be true to the story, and be real and be honest. And I think if you do that, whatever platform you use, you will make a difference in having an impact on someone doing something. And that's the thing you got to do. It's got to be true, be honest, and tell the story.
I totally agree with that. Definitely be true and honest. Look for awesome partners who will support you in this, like Zero. Zero has definitely been a champion in supporting, I'm sure the other filmmakers on the panel, but as I speak for myself, they've been so supportive in our efforts to travel with the film, doing men's roundtable discussions. Like, they've just been awesome, and finding an awesome partner is definitely important, because it is a lot of work. Like, you think you're just doing a film, but you're not. You are becoming an advocate, and it's a beautiful thing. It is a lot of work, but it's a beautiful thing. And so having that support system, especially when it gets a little difficult, you feel like, why am I doing all this? This is crazy. If you are someone who, like Reggie and Terrence, you guys are also survivors. So you're like, I got my own stuff I also am dealing with on top of trying to get the word out. It's a lot. So having a strong support system, I think, is really, really important in order to do that.
Yeah, I would add, by repeating what both Londi and Reggie said, that you have to approach it with some commitment to telling the truth and being genuine about it. I think that one thing that I would suggest to any filmmaker going to approach this topic is to make sure that you touch upon things like the social determinants of health, cultural competency, provider bias, the importance of clinical trials. I alluded to the fact earlier that addressing the disparity, it takes a kind of a overall global look at the disparity. And I think that that's critical to telling the truth, to telling the entire story. And there are just so many different components. I would also suggest that as I have benefited from these conversations that we've had previously with Londi and Reggie, talk to other filmmakers that have done this work, because they can provide a critically important insight as to how to approach it, the challenges that you might encounter, and how people will in fact work with you if you approach them in the right way. I got a lot of support from the City of Norfolk government and the medical community in telling the story.
Yes.
Great. Thank you so much. And definitely before we move on to the question and answer portion of this, I definitely wanted to give you all a moment to kind of highlight any of the other projects that you're working on, anything else that you're working on that you want to talk about. And then this is a two-part question. And then also, how can we at Zero, or just folks within the audience, right? Like, how can we continue to grow these types of efforts? I know we talked a little bit on the challenges, but like, what are some solutions that you all can kind of provide for us?
I have a project that has been going very well. It's called The Angels and the Details. My church, this is not health related, but when you talk about the social determinants of health, as my church is an African-American church, there's some relevance there. This film is about my church, the only African-American basilica in the nation. It's a Catholic church. We recently completed a $6.7 million renovation. And during that process, we made some incredible discoveries. We discovered that there were 2 underground tunnels beneath the church. One, we have very confidence played a major role in the Norfolk branch of the Underground Railroad. We discovered a cemetery beneath the church, and several of the remains that were exhumed appear to be people of African descent. We learned that the African American participation with this church goes all the way back to 1791, when the church was founded under another name, St. Patrick's Church. And it was founded by European immigrants as well as free and enslaved Blacks. That church was burned to the ground in 1856 because they were allowing Black people to attend. It is also believed that they were doing interracial marriages in the 1800s in Norfolk, Virginia. So it's just some incredible stuff. And the film has been doing exceedingly well. Again, I feel very blessed with that. That's the other project that I just recently completed, and I'm about to do a couple other things. But what I would say to Zero is, as evidenced by you having 3 filmmakers on this panel, you surely appreciate the potency of this media as a critically valuable way to deliver this important message. I would say continue on that path. Because you will not just reach people that are going to benefit from having this information, but you will also inspire people to go along that same course. And I say kudos to Zero, and I look forward to participating in I did it this year, the 5K here in Norfolk, Virginia Beach. I don't know, I'm just very, very keen on Zero.
Go ahead, Reggie. I'll go last.
Well, and you can tell folks that we're all a family. We've been through this together. Well, one of the things for me, is taking this project from the analog into the digital world, to build on the story about survivorship. I think the story is intriguing, that you have 2 different people and then the filmmaker gets prostate cancer, but the story continues. And so how do we rework the film really to bring that in, to bring it up to date technologically, but also in the way we message. The other part is to build around social media. I think it's important that, younger people sort of get the story a little bit, that they kind of have that in their memory banks, if you will. My son has been so involved in this. He is now himself a filmmaker. He started when he was about 12 years old, carrying, tripods around. And now we're having discussions and meetings about how we're going to rework this project for the 21st century. And it's such a wonderful thing. But now he understands the importance of keeping up with this PSA. And he also understands how we might be able to package this message for a younger generation. So that's important. That's something that I'm working on now. The other one is a companion podcast with If You Are My Brothers. I've been doing podcasting now for about 3 or 4 years. My son and I actually have a podcast together. It's called Boomer and the Millennial. And we've been doing it for about 2.5 years. And we talk about all kinds of issues, but prostate cancer has been part of that. Health has been part of those conversations of 2 different generations. So to really, start the rework the film, and also to build in social media and podcasting is sort of next. And understanding there are other projects, but as Londi and Terrence both mentioned, this is an ongoing thing. I think you cannot be a filmmaker or in this business and just say, I'm going to do prostate cancer and that's it. It is ongoing. And Zero, you folks, you do a great job of letting us know this is an ongoing struggle, and your name is Zero, right? To get to the point where we don't have prostate cancer anymore. So I'm very engaged and excited about still being a part of this journey.
That's awesome. Well, first, I have to say kudos to both you gentlemen. You guys are amazing. It has been fun to be on this film series journey with the two of you. I appreciate you guys so much, because it's true. Like, we all have films that touch on different things. That should tell you how vast this issue is, right? And how you can touch lives in different ways. All 3 of our movies appeal to different men in a way that can help connect them to start to think, okay, maybe it's time for me to get tested, or maybe I need to talk to my loved one about it. Coming from the perspective as a woman, I'm now my father, my brother, that we can start having these conversations. So it's been a pleasure to be on this with the two of you. And thank you, Chris, for facilitating this today. For us, we've been working on this for a while, and I'll be honest, I kind of got distracted with other projects, but now we're full-fledged. We've done some updating to the film as well, with the help of Zero. Zero gave us some awesome new stats. So we just completed some of those updates, and we're getting ready for distribution on the film. So hopefully it will be on a streaming platform near you very soon, but you can always follow where we're at with that process by going to our website, thesilentkillerdoc.com. That's thesilentkillerdoc.com. And then also, I also run a nonprofit called Women of Color Filmmakers, and we are starting a health series. So women in our organization who want to do films, documentaries, or even narrative films in the prostate cancer, not just prostate cancer, but cancer space. Right? We're starting that process. So, it's a journey, and hopefully we can eradicate some of these things that are definitely plaguing the African-American communities specifically, but just in general, just making sure that people are thinking more about their health, and that we're no longer hearing about people dying from things that if it was just caught sooner, they could have survived it, or they could have got treatment, and their lives could have been extended. That's definitely our goal.
Amazing. I definitely want to take a second to thank all of you for your honestly incredible work. I know that the impact and reach that all of your films have made just across, to all of your points, just across generations, communities, different types of folks has been amazing to see. I'm grateful for the opportunity to get to work with you all and get to know you all. You're all extremely creative people. And I don't get to say that often. So thank you so much for taking your time. It doesn't look like we've got any questions right this second. So again, if folks are interested in this kind of work, please feel free to reach out to these wonderful folks. I'm sorry I'm throwing you under the bus, but your work is so incredible. And I really do hope that more people get to see it. I know us at Zero are doing our part. And so please, if you're in the Atlanta area, quick shameless plug, in the Atlanta area on November 19th, we'll actually be showing the Black Walnut, Terrence's film at Impact Church. And So we're looking forward to continuing this series and making sure that we can spread the message across the country. So thank you all so much.
Thank you. Thank you for
Chris,
having us.
Thank you.
and thank you for your team and what Zero continues to do.
Yes, thank you.
And now I'm so pleased to announce Zero's Health Equity Organization Award. Congratulations to the Prostate Health Education Network, also known as FEN. FEN has a long history of eliminating barriers that Black men face as they navigate their prostate cancer journey. Michaela, our health equity manager, recorded a conversation with Tom Farrington about this award and his health equity work. Please watch this award presentation to FEN at zerocancer.org/HE Symposium. Again, zerocancer.org/HE SYMPOSIUM. And now a quick thank you to our sponsors. Our silver sponsors are Bayer, Blue Earth Diagnostics, Myovant Sciences, AstraZeneca, Sanofi, Pfizer Oncology, and Astellas. Zero is extremely proud to partner with all of our sponsors as we address the many topics surrounding health equity and prostate cancer. There's still plenty more ahead. We've got details on Zero's in-person prostate cancer summit in Washington, D.C. Plus, we've got an awesome interview with NBA All-Star Grant Hill and why he's so passionate about educating Black men about prostate cancer. Zero's second annual Health Equity Symposium continues in just a few minutes. We're back live at 12:30 Pacific time and 3:30 p.m. Eastern time. Thanks so much and see you then.
to Zero's Prostate Cancer Health Equity Symposium. I'm Dr. Reggie Tucker-Seeley, Zero's Vice President of Health Equity, and I am so glad that you've decided to join us today, whether you're joining us in real time or listening to this at a later date. I want to say thanks to the participants of our last session, which was focused on our prostate cancer in the Black community film series, Chris Bennett, our Health Equity Director, and the filmmakers, Londi, Terrence, and Reggie. It has truly been a pleasure to work with all of them on the implementation of an idea that came out of our Health Equity Task Force, of which Londi is a member. And as Chris mentioned, our next film screening will be of The Black Walnut on November 19th at Impact Church in Atlanta. You can find out more information about that on our website at zerocancer.org/Black Men's Film 2. That's zerocancer.org/Black Men's Film 2. Well, we begin this session with our Health Equity Lifetime Service Award. We have been so honored to partner with a lot of different organizations and individuals because health equity as a team and as a program here at Zero is relatively new, but there have been lots of groups and organizations working in this space, and it's been our pleasure to partner with them and to recognize those achievements. So this award is our Lifetime Service Award. And this award goes to a passionate advocate in the fight to zero out prostate cancer. And we're honored to acknowledge Representative Bobby Rush of Illinois for this award. Congressman Rush has represented the 1st District of Illinois for over 2 decades. During that time, he's been a powerful advocate for health equity, and he's supported legislation that reduces barriers to prostate cancer screenings for men at the highest risk of prostate cancer. And he consistently recognizes the disproportionate impact on Black men. Congressman Rush has also repeatedly lent his support to the prostate cancer research program at the Department of Defense, where researchers strive to advance health equity and reduce disparities in prostate cancer. At last year's Racial Disparities Symposium, Zero presented Congressman Rush with a Zero Impact Award. This year, we're honored to present Congressman Rush with the Zero Health Equity Lifetime Service Award. And we at Zero thank you, Congressman Rush, for all that you do. And Zero is proud to have you as a partner in the fight to zero out prostate cancer and to achieve prostate cancer health equity. Thank you. So for our next segment, during Prostate Cancer Awareness Month back in September, Chris Bennett, our Health Equity Director, and I interviewed NBA All-Star Grant Hill for our podcast, Prostate Cancer Uncensored. We had a wonderful discussion about the importance of raising awareness about prostate cancer among Black men. The audio version of that podcast was extremely popular. So we thought we'd bring you the video version today here at our Health Equity Symposium. So here is Grant Hill and our discussion from our podcast series, Prostate Cancer Uncensored. Welcome to Prostate Cancer Uncensored, a podcast produced by Zero, the End of Prostate Cancer. I'm Dr. Reggie Tucker-Seeley, Zero's Vice President of Health Equity.
And I'm Chris Bennett, Zero's Director of Health Equity, Community Organizing and Engagement. And as an ex-professional basketball player myself, I'm really excited about today's guest, NBA All-Star, Grant Hill.
As many of you know, Grant Hill is a retired Detroit Pistons and Duke University basketball player and part owner of the Atlanta Hawks. And he's also a passionate advocate for raising awareness about prostate cancer among Black men. Welcome to Prostate Cancer Uncensored, Grant.
Hello, guys. Thanks for having me.
First, we wanted to take a second just to thank you again for your advocacy around raising awareness around prostate cancer generally, and also your efforts to highlight the disproportionate impact it has on Black families. This is such important work, as we all know. Would you mind telling us a little about how you kind of raised awareness and why you got into this?
Yeah, Chris, you know, I think we all, particularly Black men, I think we all are aware and at least have someone that we know, could be a family member, a friend, someone you work with, a colleague who has been impacted by prostate cancer. For me, though, personally, there really was nobody in my immediate family. It really started with, and you mentioned earlier, the Atlanta Hawks. we started 4 or 5 years ago a sort of a prostate awareness month initiative. And, our marketplace in Atlanta, there's obviously a strong African-American presence, and sort of part of our community efforts to, really raise the awareness and with African-American men. But for me, so I was a part of that, and that certainly got me aware of the disparities in greater detail. But then to go to a step further and to partner with Dendreon Pharmaceuticals and to learn about those disparities and how disproportionate it is and how it just impacts our community, it was incredible. And so I knew at that point, as an athlete, and you would know this, you take ownership for not just your career, but your livelihood and your health. And really getting out there and encouraging all people, most importantly, African-American men, to get proactive, get off the sidelines, and learn more about this and learn how it can be treated, and then also in a lot of cases avoided if there's early screening for it. So I know it's a long answer to your question, but I think that hearing about these disparities along racial lines, I knew I had to do something and to get involved and get off the sideline and get into the game.
Yeah. So it's great that you heard about the disparity and that motivated you to get more involved and to become a vocal advocate for health equity in prostate cancer. We at Zero define health equity as everyone having a fair and just opportunity to prevent, find, treat, and survive prostate cancer. So why is prostate cancer an important cause to you personally?
Well, I mean, I think, we talk about, and not to be controversial here, but, we talk about Black Lives Matter. And to me, there's many interpretations of what that is and what that means. But I think as someone who obviously cares about our community, and certainly there's a laundry list of things that are concerning, but this is alarming when you find out that, Black men are twice as likely to be diagnosed with and 2.5 times more likely to die from prostate cancer than Caucasian men. When you find out that I think 1 in 7 African-American men will be diagnosed with prostate cancer in their lifetime. Like I said, there was no, personally didn't have this. I don't have a family member, but if you care, you want to see other people take the necessary steps, so it doesn't have to be so we can change those numbers and bring those numbers down, and really impact our community, and that's a way to do it. And so I feel like I'm kind of historically been a relatively informed person, and until I really had a chance to dive in deep, I was unaware of just this kind of impact. And so the numbers, the statistics, some of which we've shared already, once you see that, once you're aware of that, then you're like, okay, what can we do, and how can we change that? And so part of it is talking about it, it's bringing the awareness and providing the same education, information, resources to our community, that yes, this is not something that's just happens to Black men and we just got to accept it. We can figure out how to at least bring those numbers down, and try to beat this. And it's just like a game. As an athlete, you don't go into a game unprepared, but a lot of us in our community, we go into this fight against prostate cancer unprepared. So just giving a game plan, a playbook, giving the tools necessary to combat this is something that was, I don't know if appealing is the right word, but something that made me want to say, okay, how can I be a part of this? How can I change this narrative? You know, how can I change this? And so, you know, long story short, that's how and why I'm here now with you guys.
Yeah.
Awesome. So, I mean, a lot of men may be apprehensive or even nervous about being screened for prostate cancer. What is your message to any man right now that's kind of hesitant about being screened for prostate cancer?
Well, you know, we got to get over ourselves. You know, I do think, not just in terms of the screening for prostate cancer, I just think Black men in general don't like to go to the doctor. And, you know, there may be a lot of reasons for that. There may be a lack of trust. Who knows what that is? But I do think in our community, we tend to only go when there's something wrong. And sometimes we won't even go when there's something wrong. You know, I mean, and so we have to change that. And we have to go and get screened. There's other options for screening. Obviously, I think, you know, the one that I think that has a lot of people fearful is you know, look, this is your life, and this is something that can be avoided or at least treated if caught early. And that's what we have to get out there. So, you know, get over yourselves. You can get blood work now. I mean, that's an option that wasn't there maybe 30 years ago. But once again, it falls into that bucket of educating and informing, and just making people aware of these numbers, of what prostate cancer is, how it can be treated, but also if detected early, then it's a situation where it doesn't have to be fatal.
Right.
Yep. One of the things that we talk about a lot here at Zero is that, you know, in addition to educating men, we also have to educate our healthcare delivery system. So one thing that you mentioned is that, you know, African American men we may not necessarily want to go to the doctor, or we don't go to the doctor, but historically the healthcare delivery system hasn't necessarily been a trustworthy partner to us. And so I think it's going to be important that in addition to educating, you know, Black men around, you know, going to the doctor, we also have to educate our healthcare delivery system to be better partners to us. And so one of the things that you mentioned earlier were those staggering statistics that sort of really engaged you in this process. And I can tell you from my perspective as well, sort of seeing those numbers, you know, sort of really motivated me to want to do this role as well. So you mentioned, you know, Black men are almost twice as likely to be diagnosed with prostate cancer. We're over twice as likely to die from the disease in comparison to white men. What do these disparities mean to you, and why is it so important to address them now?
Well, first of all, I think it is critical that industries and healthcare, I mean, you know, are proactive, particularly when it comes to preventative and, you know, equitable care for communities of color. But yeah, I mean, these numbers are staggering. And, you know, and we also, I think sometimes as Black men don't understand the impact it has on others, on our loved ones, on family members, friends of ours. And so I like to say, you know, it's important for us to be selfish so we can be selfless. And, you know, selfish in the sense of, you know, taking care of yourself. I mean, you know, and but then also so you can, you know, do it for yourself, but also for those that are near and dear to you. But yeah, I mean, look, to me, this is something that if we all dive in, we all chip in, we all do our part, and we're proactive, we can reduce those numbers, and we should. You know, we should do that. And as I said, you know, Black Lives Matter has been a catchphrase that's been used and certainly been a topic of conversation. Well, this matters.
Yeah.
And this is important. To your point, though, about the industry, like I think part of it, you know, I think of like MADD, Mothers Against Drunk Driving. And, you know, mothers getting to a point where they were so upset, so frustrated, impacted by various deaths associated with drunk driving, that they got engaged, they got involved, and they created a movement, and they changed laws.
Yeah.
And so until we, you know, until we act like we demand certain things and we demand this from the healthcare industry, then we're going to continue to get treated as such. And so, but before we can do that, we have to become aware and we have to understand, and there has to be a demand for change. And so we're sort of in the infancy stages of that in a lot of ways. But no, I mean, those numbers are just, they have to change. And that's what compelled me to, you know, get off the sideline and get in the game.
Yeah.
Agreed. Those disparities, they have to become unacceptable to us. We have to say they're intolerable.
Right. And we've done that. I think we've done that as it relates to other issues pertaining to you know, to Black America.
Right.
But this is something where we're doing to ourselves. And, you know, it's one thing you can get into other themes, and we're not necessarily going to do that today. But we're worried about sort of what others are doing to us or unfairness or things of that nature. Well, we have to be proactive when it comes to our health and just be, you know, disciplined and get over our fears, our phobias, whatever we think is taboo. You know, that to me is about caring for the community, caring for ourselves.
Speaking of being disciplined, Grant, as an athlete, you know better than anybody else, right? We're conditioned to really take care of our bodies, right? From the nutritional piece to resting to the daily grind in the gym. A conversation that's actually come up pretty recently, now that I've been in this role, with a couple of coaches of mine, Black men, that all played, was about how surprised they were when they were diagnosed with prostate cancer. You know, one of my coaches actually felt like he had done everything right in his entire life, right? Ate well, slept, you know, didn't really go out. None of that, was taking care of his body. And then his body kind of just betrayed him. That's how he kind of felt when he was diagnosed with prostate cancer. Is that something that you've experienced before? And how would you encourage other athletes and other coaches to really begin to have the conversation about prostate cancer? And even the importance of just going in for prostate cancer screening?
Yeah, you know, that example that you use was really fascinating. And certainly as an athlete, I think you're very in tune with your body. And you know, certainly it sounds like this particular gentleman you're referring to, you know, did everything right, took care of himself, ate well, looked good, felt good, was very disciplined about all those things. And sometimes someone who's in that category can be susceptible because, you know, you're so in tune that you feel, okay, I can tell when something's wrong.
Yeah.
Well, with this, you don't necessarily feel it. And by the time you feel it, it could be too late in some cases. And so part of, you know, eating right, getting your rest, working out, recovery, you know, all of these things that I think someone who fancies themselves as an athlete, someone who takes care of themselves, someone who's going to have a long life, well, you have to add to that going to get screened, you know, and just going to the doctor in general, but going to get screened. That should be part of your regimen. That should be, you know, it's not every day, it's not every month. You know, once a year is you know, is perfect, but that's got to be part of the regimen of taking care of yourself. And but sometimes when you are in good shape and you know you can get a little bit, I don't want to say, you can be a little naive or delusional or maybe even arrogant to think that I don't need to go see the doctor because I'm doing everything I'm supposed to be doing. And certainly that's good. That's a great thing, and I encourage anyone to do that, but you have to do more. And you're willing to be that disciplined about your body, then you can throw in an annual screening into the equation as well.
I love that. And so as someone that has a huge platform, right? Especially in the basketball world and really just the Black community, right? Like, I can't tell you how many times your name has come up in conversation at the barbershop, right? You know, how do you want your message to reach and resonate Black men who look up to you and view you as a trusted person, right? You mentioned trusted partners. And where do you see or hope that your advocacy can go?
Well, I think to stay in the barbershop, a lot of times barbershop, there's a lot of things that are discussed, and one of which is sports. And, I think a lot of folks who are in the barbershops, as patrons, may at some point in their life participate in sports. And a lot of them follow sports and are fans. And I think we all understand that, you don't go into a game
right
unless you're prepared. An athlete doesn't go in unless they're in shape. There's a scouting report.
Yeah.
They understand the other team's tendencies. You go in with, giving yourself every opportunity as an athlete, as a team, and as a fan. You would hope your favorite team would give themselves every opportunity to be successful. And the same thing applies here. We have every opportunity here to not only extend your life, but have a healthy, productive life. And to deal with prostate cancer, which is a real issue in our community. So it's that athletic mindset. It's the same thing. You don't have to necessarily have been an athlete to have that, but to be prepared, to have a playbook, to have a game plan. That's what's important. That's what we're trying to get across to people. And we've been good. It's been received well, and we've certainly made a lot of headway, but we still have a lot more work to do, and we're committed to doing it.
Awesome.
Well, thank you so much, Grant, for taking the time today to chat with us about your advocacy efforts. And I think having someone with your influence talking about prostate cancer generally and prostate cancer disparities specifically is so important. Our last question is focused on how can we support you to amplify your message? That is, what can organizations like Zero do to help you in your awareness, education, and advocacy efforts?
Yeah, well, first of all, thank you guys, Reggie and Chris, for having me on, and the great work that you guys have been doing at Zero. It's, I think we're all fighting the same fight. And I just think if I were encouraging you or anyone, it's just to continue to talk about it, spread the news, spread the knowledge, and let's together, let's win. Let's win this fight.
Grant, thank you again for taking the time to sit down with us today and talk about health disparities in prostate cancer and your advocacy efforts. We really appreciate you using your platform to make your voice heard and to talk to Zero, as well as to the men listening at home to make a difference in the fight against prostate cancer.
Thank you for listening to Prostate Cancer Uncensored, a podcast produced by Zero, the end of prostate cancer. To download more podcasts, head over to zerocancer.org.
to the Zero's Prostate Cancer's Health Equity Symposium. I'm Dr. Reggie Tucker-Seeley, Vice President of Health Equity, and I've been so excited for this session all day. It's our Ask Me Anything segment, and in this segment, we have 3 doctors here to answer your questions, and these doctors are true friends of Zero. 2 members of our Health Equity Task Force, Dr. Stanley Frencher and Dr. Joseph Osborne, and a leader of one of our US2 support groups, Dr. Sanford James. Our goal with this session is to provide an opportunity for the audience to ask questions that spans from the community to the healthcare delivery system, back to the community. And so thank you, gentlemen, for joining me today. And I'll give a brief introduction to each of our panelists. First, we have Dr. Stanley Frencher, who is the Medical Director of Surgical Outcomes and Quality at Martin Luther King Jr. Community Hospital here in Los Angeles. We have Dr. Joseph Osborne, who is the Chief of Molecular Imaging and Therapeutics, Professor of Radiology at Weill Cornell Medicine, and attending radiologist at New York Presbyterian Weill Cornell Medicine in New York City. And Dr. Sanford James, who is a Project Advanced Facilitator and College and Career Advisor, an adjunct professor based in Austin, Texas. So gentlemen, welcome.
Thank you.
So
thanks for having us.
Yeah, so I wanted this conversation to really be to answer some of the questions that folks in the community might have, but until we get those questions, I've put together some questions here to get us started. So if you were able to see our first session, that is our session on what is health equity, you may have seen the video that we showed. And one of the things that we asked for providers was to be trustworthy partners to Black men as we are navigating the healthcare delivery system. So I'd be curious to hear, what does it mean to you to be a trustworthy partner? Because we at Zero are also working to be trustworthy partners, or actually have a little Post-it note, on the side of my desk that says, what does it mean to be trustworthy? And I have 3 things listed: to be competent, honest, and reliable. So for me, that's what I'm taking out to the community, to be trustworthy partner. So what does it mean to you to be a trustworthy partner? So let's start with Stan.
Yeah. Again, thanks for having us, Reggie, and I really appreciate the time to chat with you all. I think that when I start to think about being a trustworthy provider, I had the benefit of growing up with one as a physician who was my dad. And so he was someone who practiced in the city of Detroit, grew up taking care of patients from a Marcus Welby throwback type. He took phone calls from every patient. He visited them at their homes. He knew multi-generations of families. And I think that, so I start there. I think first and foremost, we have to listen to our patients and be their physician. In the broadest sense of the word. In terms of listening and being culturally humble. I think humility rather than competence is kind of where I start, meaning that we can't know everything about every person that comes through the door, but we can listen, and we can understand where they're coming from. And I think that a big part of that is not making assumptions. Even as a Black urologist, I need to take time to listen to each one of my patients to understand where they're coming from, because my experience may be very different than theirs. And so I think that that's where I start in terms of building trust, is listening, being humble. And I think the third piece for me in terms of being a trustworthy provider is really spending time in the community. So staying within the 4 walls of my clinic is not the way to do it. And so I think really, we started first by doing a lot of community outreach, working in barbershops, even though I don't go there as much for myself. I still take my son and enjoy the dialogue in the shop. And I think that that's a place where men trust the environment. They feel comfortable. They will question me more in the barbershop than they ever will in my clinic. And I feel like the questions that I get there are more pointed, are more real, and allow me an opportunity to dialogue in a way that I can't do when I'm wearing a white coat sitting in the clinic. So those are the things that come to mind for me when I talk about being a trustworthy provider.
Okay, great. Thanks for that. And I too have not been in the barbershop in a very long time, so I understand that completely. So next, Joe, what does it mean to you to be a trustworthy partner as a radiologist?
Well, once again, thank you very much for having me be a part of this panel. And I would have to echo completely the views of Dr. Frencher, because, one of the times, and this is sort of separate, During the beginning of COVID, I actually would walk to work. I'd walk down my block, I'd walk all the way down to Cornell. And I actually had to start leaving earlier because I'd run into people in my community who would say like, well, what am I supposed to do about this? What am I supposed to do about masking? You know, go by the barbershop, which I also haven't been recently, but they'd be like, oh, you haven't been around for a little while, but what about this? What about that? And it's actually on that walk through the community that people ask you a lot of questions that they may not ask you within the walls of the hospital, right? And so it's having that authenticity of being a part of when they ask you, well, are you getting this vaccine? Or, oh, you just turned 50. Did you get a colonoscopy? You know, or did this happen? And you're able to answer affirmatively what you would do in your life, what you would do with your parents, what you would do with your children. And then people trust that what you're telling them is exactly what you would tell your family. And when that happens and you're a part of it, really a part of the journey, that's when the trust happens.
So, I mean, it sounds like the key message from both of you is you have to get out of the clinic. You have to get out into the community in which you're working, which I think is a great transition to you, Sanford. I'm curious, what does it mean to you to be a trustworthy partner working in the community, working with prostate cancer survivors?
Reggie, first of all, thank you so much for having me be a part of this panel discussion. And I have to basically reiterate the same conversations that Stan and Joe said. Trustworthy, first and foremost, means you have to be present. And what Joe described about the experience of the pandemic and people seeing you in a different setting, as a cancer support group facilitator and population science guy, one of the best things to do to create this sense of trustworthiness is reliability. And so my experience is you have to be present in the community so that our prostate cancer, not only survivors, but caregivers as well, know that, my goodness, this individual is actually not separate. In healthcare, as it relates to equity, the best thing that we can do for patient care is to have people understand that we are actually present, we are part of the community, we are not actually separate. And what Stan mentioned about the white coat is a very good example. The white coat separates us. It kind of exemplifies an elitist type of status, and that actually creates barriers. I love the example Joe gave about walking to work. People now see me in different settings. Being a population science guy, I don't need to tell you how many church services I've gone to, Bible studies that I've attended, and the barbershop is a very good example. The saying goes, you know, you go to a barbershop and you stay around long enough, you might get a haircut. One of the most important things you get is knowledge, camaraderie, collaboration, and more importantly, trustworthiness.
Yes. I haven't been to a barbershop in a long time, so I hadn't heard that in a while. That is hilarious. If you stay around long enough, you might get a haircut, but if you're there, you're definitely going to get some knowledge. So, so my next question is really about inequitable care. So nobody thinks that they, as individuals, are providing inequitable care, but inequitable care is happening. So what challenges do you as providers, so this will start with Stan and Joe, what challenges do you as providers encounter in providing equitable care to your patients?
I'll go ahead and follow you, Joe.
Okay, so, well, I'm a radiologist. So to a certain degree, we're physicians for other physicians, right? So they will refer people to us. So we get whoever sort of comes. In some ways, when you're reading scans, you have no idea who's who on the scanner. You have some hints by the name, but you're not, entirely sure who's there. I think for us as a radiologist with other providers, when we have groups where we do prostate cancer with urologists, radiation oncologists, and pathologists, it's a challenge to the other physicians. And it's a challenge that doesn't have to be confrontational, because I mean, these days we all have the numbers. You know, everybody's about AI and the numbers and what's happening. And so we could very simply say, like, okay, so why don't we do this? Let's look at what's happened the last 6 months with all the providers in the room, and break everything down by race and ethnicity, and whether you offered a PSA test. Since everybody is like not biased at all, no one's gonna worry about how these results look. And in fact, we could do something where we do a look back for 6 months, and you get your data. But after 6 months, we do a look forward, and then we all see each other's data, right? And so, because the numbers don't lie, right? So someone could say like, oh, I treat everybody the same, but when you start looking at the graphs, it might look a little bit different, right? Mm-hmm. And without saying specifically, hey, when you look at your PSA and screening data, it looks off. It is what it is.
Mm-hmm. Mm-hmm. Yeah.
I think from my perspective, I put it in a few different buckets. So there's the kind of individual, like, you know, physician, allied health professional, nursing kind of factors as it pertains to how we treat patients. And then there's the systemic ones that are related to structures that lead to some of our challenges in providing equitable care at the point of service. And so first I'll start with like the bucket of providers. I think first and foremost, we all share implicit bias. Like, you know, me included, right? And so I think that when a patient is sitting in front of you, you need to be aware, like, and so there's ways to do that. There's, you know, physicians these days, we get training, we take tests to understand what our biases are going into being a provider now. And I think that that's important, like, in terms of addressing that as a potential challenge. And we have potential solutions, like you can know what yours are so that when walking into those situations, you can check yourself when a patient is in front of you. I think the other piece is the challenge that's created from the structural problems that we see. Like, and so that's more to the point of when patients have challenges with navigating the complex healthcare system, challenges with insurance status, challenges with affordability of the care that we can potentially provide. It shifts the way we take care of those patients. It just does. And I think that because like it's challenging already to take care of patients, we look at all the burnout and challenges around physicians, like in maintaining a practice and maintaining like their own wellness. Like, you know, that translates to a physician trying that much harder in complex situations where patients don't have necessarily the means to even provide them with equitable recommendations across the board. So I think there's those structural problems that we have to address that impacts the way physicians take care of patients. Like, and then there's of course implicit bias. And I will not leave off the table that there still is racial discrimination that occurs at the point of service. And we continue to have to be able to root that out, to Joe's point, by understanding the data, like providing feedback, and when necessary, addressing those kind of issues directly. And I'll leave one more point. I think in terms of the things we can do as family members and as patients is we do have to promote advocacy at the point of service. And so having some understanding of the healthcare system, allies to assist you in the process of getting care are ways to think about the challenges that we face and that you will see.
Yeah.
Yeah.
And
I would say
Joe?
even one other thing structurally, like, you know, with barbershops that are open all weekend and closed on Monday, you know, our health systems have to say like, okay, well, many of these patients work all week, so why aren't we able to screen people on Saturdays, right? Or Sundays, or why isn't that, maybe we can bring the PSA screening to the church or to the barbershop or to other places, because if we know these are barriers, that it's silly to say like, come in Wednesday on a Tuesday when we know these people who are our patients are still working, you know, because if you have to work 5 days to barely pay your rent, you're not going to take Wednesday at 2 p.m. off, which is basically the whole day. It's not going to happen. And so we have to make sure that the hospitals are providing these things because it's actually necessary to do things differently.
And so my question for Sanford is focused more so on what can patients do when they are encountering inequitable care. So what can, if this has come up in the support groups, or if you have any strategies for how can patients advocate for themselves when they are encountering what they are perceiving to be inequitable care?
Reggie, that's a great question, particularly around the idea of patient perspectives and inequity. And I'm reminded of a conversation I had. I facilitate here in Austin, Texas, a gay men's prostate cancer group. And the first thing that one of the men told me, Sanford, it'd be nice if I went into a urology clinic and they had a rainbow flag. They had something that was symbolic when I walked in, and it would tell me that they are actually being considerate of who I am rather than beyond my diagnosis of prostate cancer. And so in answer to the question about what can people do, particularly providers, I think the first thing we have to do, and it goes with what Stan was saying too, we have to recognize and acknowledge our implicit biases. But more importantly, once we acknowledge it, we have to be considerate, and we have to be humble enough to say, something, I don't understand inequity, and I'm being mindful of our healthcare system, which is a healthcare system that was not designed and created to provide equity care. It was designed to simply it was designed to provide care. As it relates to inequity, I think acknowledging those inequities, that is the first thing. And then I would say this and end it this way. I think patients themselves would love to hear a physician to say, in terms of a diagnosis of prostate cancer, they would love to hear a physician, urologist, oncologist, medical, it doesn't matter, to say, something, I haven't seen this before. I don't know. I don't understand. Let me consult with someone else. And I think inequity begins to get addressed when we actually collaborate with those of us who actually have been able to go through the necessary training to actually provide equity care in terms of acknowledgement. And I say this from the perspective, I have a PhD. I'm not an MD like these other two gentlemen, but the thing about it is I recognize as an educator, people love to say, I don't know the exact answer, but I can actually find out. And so I think inequity, particularly around providers and patients, and I'm reminded again, in my support groups, we hear a lot of people in the support groups to say, I don't mind when a physician and oncologist say, I'm going to get a third opinion. I'm going to get another opinion because I don't recognize it. And I'm going to say one last thing. One of the individuals in my prostate cancer support group was diagnosed with something called ductal prostate cancer, which I know that you all understand, but the initial urology consultation that this individual got, the urologist say, I don't really know what kind of prostate cancer you have because your PSA is only 1, but you have this nodule in your prostate and you're having other symptoms. So in terms of the PSA, that's only one indicator. We have to acknowledge the fact that there are other things that need to be considered as it relates to a diagnosis of prostate cancer. And that to me is what patients really want to hear, is that providers will say, look, I'm truly concerned with your prostate cancer diagnosis, and I will make sure that we address it holistically rather than, okay, this guy's here, I'm going to provide standard therapy because this is all I do.
Yeah. So I want to give the providers a chance to respond before I go to my next question.
Yeah, if you don't mind, I think Sanford nailed it. I think that one of my biggest passions and one of our challenges of the healthcare system is the inequitable variability of expertise that's out there. So to your point, Sanford, Like, just because you met a urologist doesn't mean you met a urologist who has fellowship training in cancer urology. Doesn't mean that you met someone who has been trained in all of our most like advanced techniques for managing advanced prostate cancer, for example. Like, and the facility where you may be receiving your diagnosis may not be a place that works in a multidisciplinary fashion, as Sanford has aptly put, where physicians of multiple specialties, oncology, radiation oncology, urology, like, are all working together to come up with a decision around some of our more complex prostate cancer diagnoses. So to your point, Sanford, I couldn't echo what you said more in terms of understanding who and what physician you're dealing with and what level of expertise is available to you, and seeking those additional opinions or seeking what we call quaternary or tertiary care at academic medical centers, cancer centers, when necessary, is really, really important, because one urologist may have a niche expertise that's not even related to cancer, given the complexity of how healthcare has evolved.
Joe?
Yeah, what I'll say, because I also believe, Senator, you really hit on something. As a radiologist, as I said, I'm a sort of a secondary provider, but I've gone to a number of the support groups, and what you come away from as a provider is the variability of how people will treat nearly the same thing, right? Mm-hmm. And so one of the things that's important is to one, have the community of people in the support group support one another, but also for them to hear that it's really okay to ask for another opinion and to really figure out where they are in the broader scheme of things, because it's really hard. We have so many potential treatments. It is way beyond many providers to know even 80% of them, right? So asking around and being an advocate is extremely important. Even people who do ask, it takes them some time to find a place where they're comfortable with what is happening with their bodies, where they're being told, that, because I tell people when they see a provider, if a provider doesn't say, oh, this is what I'm doing, but you can ask around, it's fine. If someone says, no, you don't need to go anywhere else, that's the provider you need to leave immediately, right? Because there are many opinions. And if someone thinks that there aren't, that's someone you don't need to stay with.
And Reggie, if I could just add one more point. I mean, I think that when, certainly my father was diagnosed with cancer about 2 years ago, not prostate cancer, but a rare form of multiple myeloma. And I provide that example because, the challenge was many physicians we spoke to, and I'm a physician, didn't know necessarily how to treat this disease, like even at, very well-known institutions. And because there's so much variability in how to treat these rare forms of cancer. What it proved to me was that it's important as a family member, as a caregiver of a man with a new diagnosis of prostate cancer, that we need advocates with us. That could be a friend, that could be a support group member, that can be a spouse or partner. And I think that those additional ears and eyes are critical in terms of holding us as physicians and nurses and staff accountable. It's also important to leverage those support groups and other organizations to know what types of questions to ask going into those conversations. When a patient comes to talk to me about a new diagnosis of prostate cancer, that's a 45-minute visit at a minimum. And we're going through detailed questions, options, and I still end every discussion the same way. I'm not a used car salesman. You don't need to decide today. The deal's not going to change. Go home, digest the fact that you just found out you have cancer. Diagnose, digest the fact that there are a lot of different options for you to sift through. Talk to your family, share the news, reach out to people who've had the disease, understand what their quality of life was after therapy, and then come back and talk to me. And if you want to talk to others, that is perfectly fine as well. Here are the names. of half a dozen people I trust and who I would have treat me. And if you're getting that kind of information or that kind of encounter with a urologist who's usually the one giving you that diagnosis, then that's someone that I believe you can trust and that you can work with moving forward.
Well, I was glad to hear. Yep, Joe.
Yeah, and it's the urologist giving many of those starting those difficult conversations. But as someone who's sort of looking into the bubble, it's always the wife or the husband right next to them scrolling things on a pad who's really able to hear it. They're able to hear it and process it and write notes. And a lot of times the patient who's hearing it, they can't hear anything, right? It's just too much for them to hear at one time from one person. So I'm always happy to see that other person in the room, the wife or the husband, who's the one who's really making all of the key connections while difficult conversations are happening.
So I was glad to hear you need to have either another person or another resource, because I can't tell you the number of times I've heard from men who weren't familiar with Zero. I wish I would have known about you when I was first diagnosed to sort of help me navigate this, because honestly, this sounds like a really heavy lift, of the things that we are expecting patients to navigate after they have then been told that they have a cancer diagnosis. I'd like to get back to the point about what we want providers to do. And so I'm reminded of Joe's discussion around if we present them with data around this is your practice patterns, and if your practice patterns are so far out of line from your colleagues, maybe that will sort of shift some behavior. And it's reminding me of the conversations that we're currently having in the health equity space, where I am terming it health equity fatigue. That is, for some people, they are getting tired of talking about it, and they didn't have to think about this maybe 10 years ago. And now we're adding another thing that they have to think about in terms of how they do their job. So how are providers, sort of now grappling with being expected to be health equity champions, where maybe even 5 years ago, this wasn't something that providers were being asked to do?
I want to start off with this kind of statement, and I'm really glad, first and foremost, that we're having conversations around equity as it relates to particularly prostate cancer. And I think it goes without saying, and Stan touched on it earlier, it is such a necessity today to acknowledge the fact that inequity has been occurring in the cancer space for so long as it relates to prostate cancer and Black men. My goodness, is even longer. I've been doing this work now for over 20 plus years, and I'm reminded that when we first started, and this is how old I am, there was a desire to address health disparities coming up to the year 2000, and there was something called Healthy People 2000. Then it became Healthy People 2010, Healthy People 2020. We changed the name to Health Disparities. And I have to say this, if we are truly intent and desire to address cancer inequity, we have to acknowledge structural discrimination, racial biases, and implicit biases that are part of the structures that all of us reside in. My formal education was an education of assimilation. It was an education of, okay, keep your head down, don't complain about anything, but more importantly, we are going to make sure that the healthcare system will have a funnel effect. Maybe people come in a wider perspective, but in the end, we want everyone to be the same. That is not a truth. Here we are in the 21st century. Individuals who come into the cancer space are not the same. Joe and Stan have all touched on the fact that prostate cancer is a different diagnosis for every patient. As providers encounter patients who are diagnosed with prostate cancer, it is so important to acknowledge the fact this individual's diagnosis of prostate cancer is not the same. Therefore, if we truly want to focus on patient outcomes, we have to also acknowledge the fact that everyone is different. Therefore, their regimen of treatment needs to be applicable to their diagnosis. And I'm reminded one last thing. I was actually interviewing or talking to a clinical director for a comprehensive cancer center, and this is a regional cancer center. And I asked the question of, how do you address clinical trials and patients who are seeking clinical trials for their diagnosis? And the individual informed me, we don't do clinical trials in this facility. We never mention it. So there is an equity, whether you're Black, white, Asian, doesn't really matter. If the clinical cancer center director says, we don't mention clinical research trials because we don't offer them, there's inequity. So I just want to point it out that way. We have to acknowledge cancer is different. It's almost like every person has different fingerprints. So therefore, we are unique individuals. Therefore, a diagnosis of prostate cancer is different. So I should not be offering everyone the same regimen just because that's all I do. Joe said it eloquently. We should recommend you may want to see someone else because this is the most important decision that you're going to make.
Yeah. Joe or Stan, about that issue related to, this new aspect of equity that we are asking providers to now think about, that they had not historically been, that's not historically been part of training, but also practice.
Well, I think it's important to acknowledge that these disparities of which we speak, just like Sanford said, if you look at the data from 2010, 2000, 1990, it's the same thing, right? You see the same, twice the incidence, twice the mortality, it's the same thing. So if it's not that people haven't cared, it's not that people haven't pushed, it's that certain things are not right that have to be, we at least have to address, right? And so I also spoke recently with a cancer center director, and he said, because I'm, he decided to push me because I'm a radiologist. And he said, if you look at all of the centers around the Chicago area that are certified by the American College of Radiology, they're all in the places where the breast cancer mortality is the lowest, and none of them are the areas where they're Black women, right? Like it looks like the opposite. So he's like, all of the hospitals and all of the imaging centers are in the wrong place, right? And so if people are staying within that imaging center, they're not in the place where the cancer mortality is. And you're like, okay, well, this has to be a part of our practice. I mean, yes, we're being pushed as physicians. Burnout among radiologists is extremely high, but there has to be a way to preserve ourselves, but also change practice because it's an imperative.
Yeah. I mean, from my perspective, it really comes down to support of our providers and clinicians to do this needed work. So when we started talking about quality in the early 80s, like, sadly, it wasn't a big topic before that in terms of the quality of care that we provide. Like, we talk about metrics, we talk about providing data, but we also have to talk about creating the systems that we as physicians work in such that we can accomplish these goals. And so the same with equity, like, it needs to be a part of the broader dialogue about how we construct the systems that we work in from the beginning. So, and so for those that are already constructed, we need to deconstruct some of those systems, and reimagine how we take care of patients such that they get the resources necessary for them to get the outcomes that we intend for them to have. Meaning, all types of care, be it the variability in the cancer and the individuals themselves, but also the variability in the lives that our patients bring to that treatment decision. So the work that they do, the places they live, the families that they have in support of them, or the lack thereof, are critical to understand and address at a systems level, such that physicians aren't left to alter their treatment paradigms based on the types of patients who are coming to see them. To make that concrete, I work in South LA. And so, the idea is that I am able to deliver the same care as a UCLA faculty member, which I am, that I would provide in Westwood, that I could provide in Compton. And the reality is the only way for me to do that is not what's between my two ears or not the way my hands work, but the systems in which I practice have to change the way that we embrace and the way that we care for patients. And so as physician leaders, we have to take a role in advocating for that change and making that change happen. So I would challenge providers, urologists, radiation oncologists, radiologists, oncologists in communities where they practice, where their patients are predominantly men of color, are Black men, to alter the way that those systems care for us in order to ensure that we have equitable treatment.
Reggie, can I add?
Yes.
Yeah, I just want to add one last thing, and Stan touched on it a little bit when he was talking about, just understanding what's going on. It is so important to build on what he just said. Physicians, providers have to take it upon themselves also to be cognizant and conscious of ongoing research and advancements that occur. And I collaborate, of course, with community oncologists that may not be at an academic center. And it doesn't mean that, you cannot learn new things, but I think that's part of the issue too. Providers have to acknowledge the fact that, my goodness, education is an ongoing life learning experience. And, just because you went to medical school and, in 2005, it doesn't mean you don't need to continue to educate yourself around the ongoing advancements in prostate cancer. And lastly, one of the individuals in my support group just the other night, he was recently diagnosed with prostate cancer, and he was talking about the fact that he says, I heard that they want me to take another PSA blood test, and it's a different kind of PSA blood test. And he says, I don't understand why they want me to take it, because I already had a biopsy, I have a diagnosis of prostate cancer. And I explained to him, this is great because now you're actually going to learn more about your diagnosis of prostate cancer rather than a traditional blood test. And it goes and it's aligned itself. Now we need to have providers to really advocate for our newly diagnosed people. My goodness, why not recommend a genetics test to also understand more about the correlation between prostate cancer, other cancers that might exist in your family, particularly we know about breast cancer and BRCA, but especially now, that's how we can actually help our patients.
So what I've loved about this conversation is that everyone has raised the issue that we have been really talking about throughout the day, and that is the importance not only of what individuals can do, but the fact that we are part of larger systems and we need to understand how we as individuals navigate those systems, interact with those systems, sort of not only within the systems, but across the systems, and then making sure that we all are, cognizant of the impact of those systems on those individual level outcomes. So my last question here is about provider bias. So in this discussion around, health equity, there's been a push for addressing implicit bias. So this assumption that, we may be, engaging in biased behavior, but it's not explicit. We aren't as aware of it. Are there any successful strategies that you've seen to address not only provider, we can lump in explicit bias here too, but what successful strategies are out there to help providers address explicit and implicit bias, if you've seen any successful strategies?
I'm happy to start. I think that, from my perspective, I throw it into a couple different categories, right? So one, I think that as physicians, you see systems of care requiring and insisting that we as physicians do testing around to understand our own implicit bias. And I think I had mentioned that earlier. And I think those things can be helpful at an individual level in attempting to understand like what your own biases are, such that you can at least be aware of those things and work to address them in the way that you interact with not just patients, but maybe your colleagues, maybe the students and residents you train, like, and maybe in the way that you deal with family and other staff members at your own institution. So I think it's broader than just like your own biases and the way they affect your patients. It affects the way that you interact with anyone in your life. And so I think that that's one way. I think the other is looking at the way that we approach each other as physicians. So I think that an important facet for me, as someone who chaired a department, like who runs a urology practice and service, like is that patients need us as allies when we see that behavior on the part of others, when it's explicit, particularly, and implicit, and we need training and we need instruction on how to intervene in those situations constructively. Because at the end of the day, we're only going to change the hearts and minds of our other colleagues who we see that behavior in, if we can do that from a place of trust, if we can do that in a place that's constructive, and we can do so that we can alter the way in which they practice. Like, I feel like, we're not going to necessarily exclude physicians from practice, like who have some of these biases and even are overtly racially discriminatory. But what we can do as leaders in those institutions is begin to ally with our patients and colleagues to ultimately change behavior on a physician by physician, service line by service line practice every single day by identifying when those things are happening, by teaching our students and residents like how to intervene from their positions, and being able to teach our colleagues about ways that they can change their behavior.
Mm-hmm. Joe or Sanford?
I want to add this, and I'm reminded of, some years ago, I'm a clinic coordinator, and I actually was the clinic coordinator for a prostate cancer clinic in a comprehensive cancer center. And one of the things that I advocated for with the team of urologists and oncologists, I said, if we truly want to address inequity, particularly as it relates to men of color and prostate cancer, we have to address the idea and topic of cancer before someone has a diagnosis. And I said it for this reason. We have to meet people where they are. And so one of the things that I really emphasized a lot was extending outreach and education beyond the clinic setting. When someone comes into the setting of the clinic with a diagnosis of prostate cancer, there's already a sense of anxiety, there's lots of fear. But if we can actually acknowledge the fact that, my goodness, even as it relates to screenings, there's inequity that occurs. And we have to meet people in the neighborhoods. We have to meet people where they are. This way, we actually begin to address distrust that is part of the reality of our healthcare setting today that we don't want to acknowledge because we are in the post-Obama presidency and we want to believe that we're post-racial. That is not true. I think that the current political climate exhibits a lot about inequity. More importantly, it exhibits a lot about the voices that are not heard. And so as it relates to cancer, I want to say this. We have to really begin to, first of all, acknowledge certain things, but more importantly, collaboration. Collaboration with our neighborhoods and our communities, it would truly begin to bring things to the surface that can address disparities, particularly around prostate cancer, screenings as well as treatment, in a way that can truly begin to be realized as opposed to the surface discussions that have been occurring for the last 30 plus years.
Yep. Thank you. And Joe, any successful strategies around addressing implicit, explicit bias? Joe, you're muted.
For me, one thing that I work on, I wish a little bit more successfully, but I think is very important, is even changing the environment in which physicians or other providers see their patients. If leadership, physician and non-physician, sort of put resources in specific places, or if I'm able to be at the table to say, if we can resource this hospital or clinic that's associated with Cornell, this may change behaviors. If this place has, for me, a PET scanner, or has this kind of a therapy suite, or sees this kind of patient, or has these kinds of hours, I think it really empowers people to see them and be with them at the place and meet them at where they are, right?
And can I add one more thing, Reggie?
Okay.
Like if it's okay. And so I think that the other piece that we don't want to ignore is the lack of diversity amongst the types of clinicians that we see, right? And so, and I'd be remiss if I didn't at least speak to that when you talk about bias, because I think that first and foremost, when we think about Black urologists, like the percents are in the single digits, like, and the idea that we're going to provide equitable care with a homogenous or non-diverse workforce is, I think, a contradiction, right? And so I think the only way for us to truly get to a place where bias is not affecting our patients is if we have a diversity of voices and types of folks, not just racially, but from a sexual orientation perspective, from a gender perspective. Like we need those different voices to be a part of the healthcare system at the level of physicians, trainees, nurses, on down to EVS. Like, I think the other piece is we need physicians to train and learn and work in diverse environments. And so I think that if you're at an institution where you're only seeing one type of person come through your door, that is not the place where we want trainees to be trained, frankly. And so we have to be able to be working with the very types of folks that are and working and living and interacting with, in order to understand how to treat patients better and to expose our biases as we're learning how to practice, rather than at a time when we're a fully minted physician now thrust upon our patients and communities of color.
Reggie, do I have time for one more comment?
I could spend the whole day talking to all three of you about this topic, but unfortunately we are running out of time. But I did want to give each of you 30 seconds to sort of give us your closing comments in our Ask Me Anything discussion. It can be based on any of the topics that we've talked about throughout the day here at the symposium, or just something that we've talked about in this session. So I'll start with you, Sanford. You can jump in with the comment you were going to make. So I'll give you 45 seconds. And then your closing 30 seconds.
I want to say it like this. I recalling very short time ago in March of 2020, we faced a pandemic, COVID-19, which is still around. But one thing that happened, the healthcare system shifted itself, and they began to address inequity in a way, not just telemedicine, but telehealth. But it was an acknowledgement of inequity in the system. And I would say that the examples of ways to address things started in 2020, when we recognized that there were many of our patient populations who had inaccessible care, and we were trying to think of ways to do it. And I would hope that we would continue to expand on the lessons we learned from 2 years ago.
Great. Joe.
So I'm going to use my 45 seconds to talk about the workforce, right? And because just reflecting on what I had said before, and also what Dr. French was talking about, when I was talking about the regional cancer director who talked to me about imaging and where they were, well, that was Robert Wynn, right? Who is the head of the VCU Massey, Black male, who was talking about these things, because we have to be present. Our workforce, same with radiology, low single digits, urology, low single digits. And so to be able to be part of the process of welcoming patients in, right? It's having being able to have the rainbow flag, or being able to, talk to patients about what my father would do, what I would do, or what my son would do, and have them understand the perspective that I'm coming from, right? And so I have to be there, right? I think it's very important. And I think, there are many members of different communities that need to be there too, but this issue in particular is the issue of my life. And so being there as part of that workforce, that physician workforce, is extremely important.
Agreed. Stan.
And I'll just say that, speaking directly to, if there's men out there who are watching this and who, are concerned about engaging with a health system that has historically been a challenge, has historically left us behind, understand that the first and foremost thing you can do is take your care into your own hands, work with your family and support groups and organizations like Zero Cancer to get the care you need. And to my colleagues, to my other urologists and physicians out there, we need to be the change agents to ensure that our patients have access to equitable care. And that's on us. Systems are only made of people. And at the end of the day, we have to have the agency to change the very systems in which we practice, with the goal of being able to take care of all men who come to see us. And me in particular, I'm interested in making sure that Black men have equitable access to care. So with that, I appreciate you having me here, Reggie. I too could speak all afternoon on these topics, and tomorrow again on Sunday at church.
Yes.
But
yes.
Thank you again for having us.
So thank you to Dr. James, to Dr. Osborne, and to Dr. Frencher. We had a whole list of questions. So as you can see, we could go on and on talking about these issues, but it was just so great to have this conversation, one with a panel of other Black men, so that Black men in the audience can see us. We have to be in the room in order for these issues to come up. And so, one, I appreciate your time. I appreciate your partnership with Zero, and I look forward to our continuing to work together. So as we wrap up today's symposium, I'm proud to announce Zero's Health Equity Individual Award. Congratulations to Mr. Jeff Fortson from Atlanta. He's a prostate cancer survivor and has been a passionate partner in spreading Zero's message about prostate cancer and health equity, connecting to partners in Atlanta, and also helping us to spread our message in the Southeast has been made easier for our team because of Mr. Fortson. Please watch the conversation with Mr. Fortson and our Health Equity Director, Chris Bennett, about this award. So please check out that conversation and all of today's award recipients at zerocancer.org/HE Symposium. And now I also want to tell you a little bit about Zero's Prostate Cancer Summit in Washington, D.C. So this event is the premier annual prostate cancer event, offering support, education, networking, and advocacy opportunities to empower those affected by this disease. It's happening in DC from February 26th to the 28th, and you can also attend virtually. And so you can sign up today at zerocancer.org. We'd also like to thank our sponsors for today's Health Equity Symposium. Specifically, our silver sponsors are Bayer, Blue Earth Diagnostics, Myovant Sciences, AstraZeneca, Sanofi, Pfizer Oncology, and Astellas. Zero is proud to partner with all of our sponsors on the many topics explored in our symposium today related to health equity and prostate cancer. So thank you again to those of us who are still with us, who've joined us today in real time, or for those of you that are watching virtually. I just have a couple of closing comments to make about our symposium. I'll start with our definition of health equity. Health equity means that everyone has a fair and just opportunity to prevent, find, treat, and survive prostate cancer. And that means that we're going to have to remove all the obstacles, all the barriers that we've talked about today to a usual source of healthcare and to coordinated high-quality specialty care. And also ensuring that families have the resources to manage their health and navigate the primary and specialty care delivery system. Throughout our discussions today, it has been highlighted that the pathway to the disparities that we see in health generally and in prostate cancer specifically, that pathway is deeply rooted in the history of our country and the policies that created the segregated environments that we still inhabit. Our speakers today highlighted that the pathways to disparities are multi-level, and that the universal approach alone may not help us eliminate these disparities. We need to not only understand the federal level factors that have created the differences we see in prostate cancer outcomes, but also local implementation and outcomes. And this suggests that we need to focus on universal and local solutions. We were also introduced to a field that many of us may not have been exposed to before, cardio-oncology, and the importance of thinking about pre-cancer stress levels and the implications of prostate cancer treatment on cardiovascular risks and outcomes. We look forward to continuing to amplify the ABCDE approach that Dr. Guha mentioned. We also discussed today the disparities in clinical trials participation and the multi-level barriers that patients generally and that Black men and other racial and ethnic minorities experience as they navigate care and get connected to clinical trials. What I appreciated about Dr. Borno's presentation on this topic was the call to action for those designing clinical trials to remove barriers and not just focusing on what patients need to do and know. Another key topic that Dr. Borno raised that we on the health equity team at Zero are very eager to explore is differentiating between genetic variation, ancestry, and race, and the need to better understand each of those terms and how they impact our health and how we navigate healthcare. The panel by the filmmakers was so inspirational and highlighted this new empowering tool to raise awareness. And these films are all part of our Prostate Cancer in the Black Community film series that was born out of our Health Equity Task Force. And we're starting that film series in Atlanta and eager to explore other cities. The initial response from the community has been incredible, and we look forward to screening these films to amplify the experience of Black men in prostate cancer in many other cities. Now, across these presentations, the importance of thinking and acting across multiple levels was a common theme today. Individuals, community, healthcare systems, various levels of government. And it's important that we not only ask, what can individuals do, but also what can the systems in which those individuals are navigating do better as well. We at Zero look forward to continuing to raise awareness about the differences in prostate cancer, educating our community about what we all can do as individuals, in our roles as healthcare providers, healthcare system administrators, community members, researchers, advocates, citizens in our cities and in our country. And at each of those levels, we can be champions for equity and ensure that we don't come back here year after year for this symposium and see no difference between the experience that Black men have and other racial and ethnic groups have as they navigate their prostate cancer journey. While our overall goal at Zero is to zero out prostate cancer for everyone, until that happens, we have to focus not only on a universal approach, but also a targeted approach for those most impacted or most at risk. This ensures that we all cross that finish line of zeroing out prostate cancer together for everyone impacted. So thank you so much for attending Zero's second annual Health Equity Symposium. All of today's content will be available on demand on Zero's Facebook and YouTube pages, as well as at zerocancer.org/health HE Symposium. Thank you again and have a great day.